We are about to resume the Professor P. Ravindran session. The delegates kindly join us in the old auditorium. Inviting the speaker, Dr. Nijil Haroon, onto the dais.
So good afternoon. So we will start with the post-lunch session. So this session will be a continuation of what we had in the morning. That is, we talked about the post-COVID lung syndromes. And then a lot of questions during that session was pertaining the immunology of COVID-19. And we told that all these questions will be addressed by you during the current session. So my pleasure to introduce the speaker for this session, this immunology of the COVID lung. Dr. Nijil Haroon is a 1993 MBBS pass out from Trivandrum Medical College. He is the Associate Professor of Medicine and Rheumatology at University of Toronto, Chairman of AKMG Convention in Toronto. He has received many awards, which includes the Breckel Award for Spondylitis Association of America, Young Investigator Award from Canadian Rheumatology Association, and he has extensively published in the field of ankylosing spondylitis. And we all know that what COVID-19 has taught us in the last 2.5 years is that even for infections, targeting the immunology is very, very important. As we discussed, majority of the medications with mortality benefit are the immunomodulators. And one thing that struck us during the treatment of COVID-19 in the initial days was that even though majority of the patients who used to die happened to be those with comorbidities or elderly, there used to be a subset of youngsters without any comorbidities who used to succumb to the disease or who used to develop severe pneumonia. And then, since COVID-19 was there not only in the neglected parts of the globe, it was there in Europe as well as USA, there are a lot of studies which went on and told that it was due to missense mutations in toll-like receptor 7, etc., which predispose the youngsters to develop the severe COVID-19. So to enlighten us about the immunology of COVID-19, I would like to invite Dr. Nijil. Over to you, sir.
Thank you. Thank you very much, Dr. Arvind, and a pleasure to be here always, and always thankful to the organizers for giving me this opportunity to come back to the place where you learned the basics of medicine. And trust me, I never thought I would be here standing along with the giants of medicine when I was doing my medicine and just trembling to go into the clinics. So I'm really humbled and feel so blessed to be here. Thank you for the opportunity. We've been dealing with COVID-19 for 3 years now, and almost everybody, even my son who is 11 years old, knows a lot of things about COVID-19. Some of the things he knows I don't know, because there's a flood of information coming out from many centers in the world. So my idea is not to be really exhaustive, considering the time constraints. It's just to give you a few snippets here and there, which I thought were interesting. And we'll end up with a focus on lung, but we'll start with maybe a few introductory thoughts on the immunopathogenesis of COVID-19. And hopefully, if we have time for discussion, we will try to bring all the concepts together. So this is very familiar for all of us, and when it comes to immunopathogenesis, it is the spike protein that is most interesting for all of us. Although there are immune responses to different parts of the actual virus, but it's the spike protein that is really of interest to us, and we will see, and we all know why. This is an electron microscopic picture of how the SARS virus enters the dendritic cells. You can see very well how the virus particle goes to the surface of the cell, and then over a period of time it gets into endosomes. And now we know that you don't really need an endosomal pathway to get in. It can get in without being through an endosome. A direct invasion is also possible. You can see the viral particles within the cell very clearly. So these were very early days of our understanding. And we realized that the spike protein connects with the ACE2 receptors as the binding molecule, and then we need a protease. Once the binding happens, we need a protease that helps cleaving this 1S2 site so that the virus can actually enter it. And our earliest understanding also was that TMPRSS2 was the protease, but now we know that there are TMPRSS2 independent pathways to get in. Furin is a good example. Another important molecule that may be important is cathepsin, which helps in the spread of virus from one cell to the other. So a lot of progress has been made there. The other interesting thing also which we noticed very early on is the humoral immune response to COVID was not like most other infections that we see. We usually see an early on IgM response to a viral infection or a bacterial infection. A little bit of time passes, and then the T cells get activated through the CD40 ligand interaction, and then the class switching happens to IgG. And with the IgG, our stronger antibodies, they're much more helpful for us in protection against further spread and in further infections. As opposed to, if you look at this figure, you'll see that IgM and IgG responses start on almost very similar timelines. And if you look at, if we take a large cohort of patients, a large bulk of patients would have IgM and IgG coinciding. And in some, you may even have IgG preceding IgM formation, which is, if you think about the basics of immunology, it doesn't make sense. But what is immunology other than just a rearrangement of a few small genetic components? So perhaps SARS-CoV-2 is driving a recombination in a way that IgG comes up earlier than IgGM. So that's another interesting observation that we have seen very early on itself. And as Dr. Arvind was alluding to earlier, one of the major features of SARS-CoV-2 infection is that the severe complications and mortality are not primarily due to direct viral invasion of cells, but rather due to our own immune responses that go overboard, and in the process of trying to protect us actually ends up being detrimental. And we had these 4 different stages, and these 4 different stages are very closely associated with the immune processes that are happening in our body. And as you can see here very clearly, the mild and moderate symptom phase is when the virus actually enters. When you go into the severe symptom phase, you will see that the primary, the Th1 responses, the interferon responses are actually lower when it gets to severe manifestations, which is not what you would expect with a viral infection. You want the body to pump out a lot of interferons to get rid of the virus. But here, when the patients have severe symptoms, you have lower interferon levels. You see a lot of chemokines being pushed out. The chemokines are key for bringing in all the immune cells into the target tissues. And here, in fact, these immune cells may actually be detrimental, causing end organ damage. And finally, you will see that the balance that we see early on in the immune cells. So very early on, you see lymphopenia. T cells are decreased. B lymphocytes have a relative decrease in numbers, but you see that the mononuclear components, the monocytes and the macrophages, are higher. But over a period of time, what you see is that the T cells get specifically activated, and you start seeing an increase in Th1 and Th17 cells, leading to an overproduction of interleukin-1, interleukin-6, and TNF. And we know that these are target cytokines that we use for treatment. We already had the session on treatment, so all of that was discussed. So these are the cytokines that have been identified to be elevated, and you will notice that most of them are well-known markers of inflammation: IP10, MCP1, TNF-alpha, IL-6, and IL-2. So these are the early laboratory findings. I won't take any time here, but these are things that we know. But for severe disease, we know that there are some components that we can use very early on to identify patients who may go on to severe disease. Lymphopenia and neutrophilia may be one factor, but still one of the most important factors appears to be D-dimer elevation and lymphopenia, again coming to the lymphocyte decrease. Later on, we'll talk about a little bit about how the lymphopenia happens. D-dimers, this is just an example of D-dimer being very closely correlated with mortality in COVID-19. And finally, again, Dr. Arvind already mentioned that one of the earliest findings was that comorbidities are really important when it comes to mortality and severe disease. So with all of these observations, there were very early hypotheses on what is actually happening in the body. How is it that COVID-19 is so different from SARS-CoV-1 and other viral infections? And we have all arms of the immune system being involved here, right from antigen presentation, cellular immunity, and humoral immunity, all being different from what we have known as normal viral responses in the body. One of my earliest, I'm primarily a rheumatologist, so one of my earliest striking things from SARS-CoV-2 presentation was the distribution of the SARS-CoV-2 pneumonia patches. They happen to be very subpleural, and there's a lot of interstitial changes that can happen in these patients, but very severe lung involvement out of proportion to the kind of X-ray changes that we see. And this was very, very closely mimicking a kind of myositis that we see in our clinics. It is a more recently identified kind of inflammatory myositis. And that myositis it manifests as dermatomyositis because there are dermatological manifestations. But the key thing is that it's associated with an antibody against MDA5. So melanin differentiation antigen 5. And I was thinking, how could it be possible that there is such a striking similarity between these two? And interestingly, this MDA5-associated myositis also does not behave like usual myositis. In MDA5-associated myositis, you can have normal CK levels. You may not have actual muscle weakness, but you have a lot of interstitial lung disease with subpleural patches, as you see in the CT scans here, very similar to what you see with COVID-19. And you can have cytokine storms also with MDA5. And the skin lesions, actually what you see in anti-MDA5 disease is more like a vasculopathy or vasculitic-like lesions, again, similar to what you may see with skin lesions of SARS-CoV-2. And this is just from a case series. I just wanted to show you some of the features that you may see with anti-MDA5. And here are the subpleural opacities that you see with MDA5. You can see in the antelix, you can see nodular lesions, a lot of skin lesions, the typical vasculopathy associated ulcerations that you can see. Another example where you can see a dermatomyositis like periocular rash, you can see, along with the dermatomyositis like rash and along with atypical rashes. So interesting thing is that MDA5 is actually a pattern recognition receptor. So we talked about toll-like receptors, and now earlier on TLR7 was considered to be an important factor that may be determining the pathogenesis of SARS-CoV-2. We all know about toll-like receptors. Toll-like receptors are membrane-bound pattern recognition receptors. You have TLR4 on the surface, then you have all the TLR3, 7, and 6 in the endosomal compartment. So once the virus particles get inside, the virus particles are detected by TLR7. The cell produces a lot of cytokine response. You get rid of the virus, and that's how we are protected by an innate immune mechanism. Now, apart from these membrane-bound pattern recognition receptors, you also have cytoplasmic pattern recognition receptors. RIG1 is well known. Another one I'm sure you all know is STING. And there was a famous case series which came in New England Journal of Medicine of kids developing interferonopathy related to STING. MDA5 is a similar cytoplasmic receptor for viruses that leads to production of interferons. So there was that interesting spark. Oh, here is the connection between perhaps what I'm thinking is, I'm not sure if this is true, but perhaps we now know that the ACE2 distribution is very common in the alveolar spaces, and that may be why the subpleural spaces are getting affected. Perhaps the MDA5 expression is also similarly distributed, leading to a similar pattern of recognition. And now we know that interferons are very, very important for COVID-19, and severe COVID-19 is associated with a relative type 1 interferon deficiency. So here is an example of where MDA5 innate immune responses was earlier on identified as part of SARS-CoV-2. I would extend it to a few other clinical observations. So I was just trying to find out if there have been reports of myositis in SARS-CoV-2 patients. And in fact, some patients with coronavirus infections, COVID-2 infections, can have myositis. It is not a very common presentation. But even more striking is there is a case series of individuals who got vaccinated against SARS-CoV-2 and developed myositis. So again, just showing that perhaps activation of the interferon pathway through MDA5 may be underlying all of these processes. Okay, now we move on to the actual pathogenic processes, and I'll try to finish this very quickly. We don't know exactly what is going on in each individual organ, but there are a lot of studies that have come out that have given us a clue as to how complex the process is. So if you look at the immunogenic processes, there are direct cytopathic effects that have been described. So the virus can directly infect the cell and cause cytopathology, and it can cause pyroptosis with killing of the cells, similar type of process, but here due to a direct viral infection. We know that once the ACE2 clubbing happens with the spike, the ACE2 gets endocytosed, leading to a relative decrease in ACE2 levels, leading to an overactivation of the renin-angiotensin system, and that can be pathogenic. We talked about the cytokine storm that happens as a result of activation of the innate as well as adaptive immune system. Interestingly, there is a lot of autoinflammation and autoimmune responses that have been triggered as a result of SARS-CoV-2, and I have a slide on that, so I'll leave it for that. One of the other striking manifestations which we have recognized very early on is the coagulopathy. And again, I don't think for an individual patient you can really pinpoint what is behind the coagulopathy, but a number of factors behind coagulopathy have been identified. One would be the exocytosis of procoagulant factors from the endothelial cells. Actual thrombotic microangiopathy may be involved. Virus directly cytopathic effects on the endothelial cells, leading to the loss of the smooth endothelial covering. Complement activation mediated as well as cytokine mediated thrombosis may be involved. And again, if you look at the large cohorts, unlike in a lot of viral infections, thrombocytopenia, although can be seen, I would say it is not as common as other viral infections. In fact, you may actually have platelet activation in these cells, in these patients, leading to more of a thrombophilic manifestations. So these are the autoimmune manifestations that have been seen, the MIS-C in children, the MIS-A in adults, the Guillain-Barré syndromes, the platelet-related thrombocytopenias. We can have an SLE-like manifestation along as with many other viral infections like EBV. Genetic variations, another important factor that may contribute to the pathogenesis of COVID-19. And along with all of these factors, the primary genetic factors that have been linked are related to ACE2 expression. Obviously, if there is higher ACE2 expression, you have greater viral pathogenic effects. Similar to what we have known that as the virus load is higher, the pathogenesis is higher. So if the ACE2 levels are higher, naturally the pathogenesis will be more severe. And all of these other genetic manifestations that have been identified, including interferon and ABO. It's very interesting. I don't know if you believe in the ABO association, but there have been studies that looked at ABO association, and it looks like type A blood individuals have a slightly higher risk of COVID-19 severity and susceptibility. So this is the title is missing, but this is primarily to indicate that HLH is another manifestation of COVID pathology, and that also can be triggered by activation of the pattern recognition receptors that we have seen. Finally, we move on to the last part, which is the pathology that we see in the COVID lung, and there are significant pathological changes that you see, which you don't expect that much with the usual COVID and usual viral infections. I even have experience with a patient that we saw in the ICU, a very young lad, 18, 19-year-old kid, who came in with remote COVID infection and progressively getting worse, with shortness of breath, falling oxygen levels. And then the x-rays are showing almost near complete collapse of the lung. And over a period of a few days, they tried to put him on a ventilator, trying to get positive pressure ventilation, ended up with barotrauma, pneumomediastinum. And over the next 2 months, this kid progressively got worse, and at the age of 19 ended up with a lung transplant. And what was most striking is that both lungs were just solid masses. No evidence of fibrosis anywhere in the lung. They were just solid masses. And it was so difficult to explain, how is it that the lungs are so collapsed and you're not able to get them open up? There is no significant pneumothorax. There is no significant fibrosis. Repeated CTs didn't show that. So something very, very unusual is happening. And now we have some pathology studies and also mass cytometry studies directly from autopsy lungs that give us a little bit of hint. For example, here you see significant fibrin deposition in the lung. you see significant fibroblast activation and collagen expression in the lung. You see a lot of immune cell infiltrates here, and it's primarily a lymphoplasmacytic infiltrate that you see, and also you can see thrombosis. So all the processes that we have discussed before are happening within the lung tissue itself, of which thrombosis is an important part. That plays a role in the pathogenesis. Apart from the lung, there is DVT that you can see. Patients can end up with peripheral vascular thrombosis leading to gangrene. You can also have neurological manifestations as a result of these thrombotic manifestations. The leading proposed mechanism, as I've mentioned, is still vascular endothelial dysfunction, hyperinflammation, and hypercoagulability. The other mechanism that was proposed earlier on, I didn't really catch a lot of attention from a lot of people, but still I believe there is still some sense in thinking about this. So we know that the renin-angiotensin system, ACE2 plays a significant role in converting the angiotensin 2 to angiotensin 7 and 9 amino acid breakdown products, which are more vasodilatory. So if you have low ACE2 levels, you have a more prothrombotic and vasoconstriction effect. So that makes very good sense in my mind. Okay. The immune abnormalities that you've seen in the lung that are correlated with a bad lung disease, and this comes from dysregulated myeloid cell compartments. And here you can see a study where CyTOF, single cell RNA sequencing, using two techniques, the 10x and the Rhapsody system, and flow cytometry were combined. So a multi-omics kind of a study. And these are more recent studies that have come out, giving us a better idea on what exactly is happening. And you can see that in the milder COVID lung patients, they have active CD14 monocytes. But when it comes to the severe disease, you have emergency myelopoiesis. You actually have neutrophils, a lot of netosis. You have early forms of neutrophils being pumped out of the bone marrow. And these neutrophils, usually neutrophils are helpful for us in protecting us. But when there is emergency myelopoiesis, these early neutrophils may even be immunosuppressive. So instead of protecting us, they are suppressing our own immune system and leading to worse lung disease. And also the monocytes are dysfunctional. They're not functioning properly with cytokine release or with proper antigen presentation. Single cell studies, and again, I won't go into details, but this is just to show that techniques have really helped us in understanding the pathogenesis of COVID-19, as with many other diseases. And in this single cell study, what was done is that lung tissues are broken down, and you can actually study what is happening within each single cell. And as you can read very easily, and I'm not going to go through each of these points, ACE2 expression, and this was what I was saying earlier, ACE2 expression is very closely correlated with the expression of the TMPRSS2 within cells, and you can very closely see that it is found in epithelial cells, it is found in the lining of bronchial cells, and that is why the lung is a primary target for SARS-CoV-2. This data comes from a meta-analysis of 31 lung studies. So it's a very large study looking at 31 studies, and this is what essentially they have found out. So the secretory molecules, the secretory cells, the multiciliated cells, the basal cells in the gut, these are the highest cells expressing ACE2 levels. In the lung, it is the 81, 82 cells, and also the bronchial lining cells that are the highest expressors of ACE2 levels, showing that they are susceptible for SARS-CoV-2. And there are also large atlases of COVID lung now available, and this is just an example to show you. And this is from a rapid autopsy program. Again, this just comes to Mohan and Kundamil sir. We were discussing yesterday how teams can come together and help us study. So this is a rapid autopsy program that was established in the US, in one of the sites in US. And all organs are rapidly collected and snap frozen, and single cell RNA sequencing in down on these samples. And what you see here is an atlas. Each cell can be mapped very closely because of these cells that have been identified. I'll skip this in the interest of time. I wanted to show you one. I don't think I have it. So I just wanted to show you that there were 35 different divisions within that university that came together for that particular study. There were 9 first authors in that paper, and there were 6 last authors who had equal contribution in that paper. So it just shows how collaboration helps to get you into a journal like Cell or Nature these days. And we really have the capacity, we have the numbers, we have the intellectual ability, but it just have to come together to do these kinds of studies. I think in the interest of time, I'll stop there. Thank you.
Thank you, Dr. Nigel, for the excellent discourse on immunology of COVID-19. On want of time, I think we will limit questions to 2. Okay.
That may be possibly due to an asymptomatic infection that he had prior.
That's possible. There are cross-reactive. That was one of the early theories. Antigen-mediated cytotoxicity, antigen-dependent enhancement (ADE) is one of the early, reasons for increased mortality in COVID-19. But I don't think that has really stood the test of time. Yes, we have had multiple other coronaviruses in the past, but these IgGs are more specific for SARS-CoV-2. So I'm not sure, is it because of early asymptomatic, because this was seen in very first phases of the pandemic itself. So unless we fail to recognize the pandemic before that. Yeah.
The cause of the lymphopenia and the increased neutrophils, neutrophil rise is just compensatory. Lymphopenia is due to the T cell activation.
So early on you see T lymphopenia and B lymphopenia because of direct viral invasion. Direct viral invasion and pyroptosis. The T cells die because of that. Sir.
Is there any consensus regarding the length of anticoagulation treatment if there is a thromboembolism in the US?
I don't think.
We have it at 3 months, and if they have a severe pulmonary embolism, we continue for another 1 or 2 months.
Yeah, I don't think unless it is driven primarily by the comorbidities and other history. I don't think for each individual patient you will have to individualize it. I think the 3 months would be the general one, but it's not applicable to all.
Yes, please.
See, the ACE receptor presence or expression is highest in both the lungs and the kidneys. Yes. But we don't see that much of involvement of the kidneys in COVID as much as the lung. Is there any reason for that?
So earlier on, I've read reports of renal involvement early on, and that was surprising to me because I was thinking, where is the exposure coming from? I think the reason why the lungs are involved is primarily because of the exposure, but of course through bacteremia, viremia, the virus can approach there. I also thought that earlier on the renal involvement is because of either hypotension or mediated by medications. But now we know that direct viral invasion of tubular cells have been documented in autopsy studies. So direct viral involvement can be seen. Now, why is it not that commonly seen? Is it because of the level of expression of ACE2? Perhaps that is one of the reasons. Or is there the immune milieu within the kidneys? Maybe it is not as appropriate as in the lung and in the gut. Similarly, in the gut also, we see a lot of viral cytopathy within the gut as well. Yeah.
So just one thought process. You were saying about anti-MDFI similarities between COVID and anti-MDFI.
Right.
I think one of the connective tissue diseases with a lot of pneumothorax and pneumomediastinum is also MDFI. The pneumothoraxes and the pneumomediastinums, I think, is more common with the MDFI also.
That's correct.
So,
That's correct. Yeah.
So why wasn't immunomodulators other than steroids promoted, in spite of it being a thought process of a vasculopathy or a vasculitis?
Yeah. So even in MDA5. It is a highly lethal disease, right? Even now with all the available treatment modalities, in some centers you see 50% or higher mortality for MDFI disease. So even in that disease, immunomodulators are not helpful. So this is purely based on our experience. So I think each disease is different.
Thank you.
Yeah.
I would like to acknowledge the contribution of Nigel and Nisha. When we conducted webinars during the COVID time, we conducted 15 of them. They were very helpful. They came for some of the webinars. For many, they found us good contributors. So the Trivandrum Medical College Alumni Association would like to acknowledge their contribution during that time.
Thank you very much for the excellent session. Thank you.
We humbly request the chairperson, Dr. Aravind, to hand over our token of appreciation to Dr. Nigel Harun. Delegates, please note, a vehicle of number KL01BY5070 is parked in a way causing traffic inconvenience. We request the owner of the vehicle to remove the same. The number is KL01BY5070.
Now, we'll be having a session on aging rusty pipes, calcium score lipids, and heart diseases. We invite Professor Dr. Venugopal K to chair the session.
Good afternoon to you all. I would like to thank the Alumni Association for having given me this chance to chair this session. There are two functions of the chairperson. One is a more pleasant job of introducing the speaker. The other is to introduce a subject. I'll just touch upon the subject and then go to that more pleasant job subsequently. Doctor, we have atherosclerotic cardiovascular disease or any vascular disease is probably just because the COVID came, the importance of this vascular disease came down a little. But still, it is the leading cause of death all over the world. And we need to understand the pathophysiology and the treatment modalities that are emerging in this field, especially because you find a lot of youngsters suddenly passing away during their gym or their public performances. All this is now generating a lot of interest. So we need to understand the basic mechanisms of why all this is happening and how we can prevent. The next part of this thing is to introduce Dr. Najib, who has been my student for the last 30 years probably. We started together in Alleppey. Then we belonged to the same alumni of the Sri Chitra Institute. I was the second batch. Najib came much later. And the third interesting thing about Najib and me is that we both took the fellowship of the American College of Cardiology standing next to each other in 2008, 2009. So there are a lot of personal interactions between me and Najib. And he's one of the brightest postgraduates I've ever come across. Not only bright, but he is also an inquisitive nature. The moment you finish a presentation, you find Najib getting up and asking some questions, some of them which as a speaker you may find it difficult to answer. The only other person whom I can compare here is Dr. Thomas Titus. So I think with this introduction, I would now invite Dr. Najib. You can just see his credentials here, and he is currently in Cleveland Clinic looking after the director. He basically switched from clinical cardiology to electrophysiology, and that is his passion. So with all this introduction, let me invite Dr. Najib for your presentation. I'm sure it will be eye-opener. Thank you, Najib.
Thank you very much, sir. You actually really introduced me to cardiology. As you really said, we remember the times that we spent in the ICU of Alleppey Medical College. Thankful for holding my hand in this wonderful field, and thank you for the Trivandrum Medical College Alumni Association. We started thrombolytic therapy here back in 1988. It's a long story at that time. 86 good, and that's the project that we started. It's a long story. Shiva knows it very well. It is always, such a proud moment for me to come back to this august audience. I thank the Alumni Association, Dr. John Panikar, Vasudevan sir, for inviting me and giving this opportunity. So we are talking about this aging rusty pipes. So this is the pipe supply, the plumbing work. We may think that of a third world country, but no. This is actually in Detroit, Michigan, in actually United States. It was a huge controversy how the lead leach into the water and cause problems for lead poisoning in the young people there. This is not too far away. The recent controversy that happened there. Exactly similar kind of thing can happen to our blood vessels. And this is a badly atherosclerotic aorta, as you see. So atherosclerosis is really bad. It can affect all vascular bed of the coronary arteries, of the cerebral arteries, peripheral vasculature. It can affect the aortic valve. It can cause aortic stenosis. So all these things can lead on to a huge disease burden. So as any case, we will start with a classic patient of atherosclerotic vascular disease, past middle age, multiple risk factors, presenting with angina and claudication, and got all the classic risk factors, and you cannot tolerate statin because of terrible muscle pains. Physical examination was classic of multiple bruits and diminished pulses. ECG and echo are unremarkable. Lo and behold, the primary care physician has already done a calcium score for this patient. We'll talk whether it is appropriate or not, but he comes with this heavy calcification in the coronary arteries. You can see that this is the left main stem, and this is circumflex, this is the left-handed descending artery, and this orange structure, of course, is the vertebra, and here the densities looks like exactly the same because of the calcium deposition, and the calcium score, if you calculate here, come to close to around 3,000, really high. So, and this was a CT angiogram of the neck vessels. You can see that left common carotid almost completely occluded there, left vertebral occluded there, there is subclavian stenosis, and also right internal carotid has got occlusion there. So it's just basically the circle of Willis is maintained mainly by that one vertebral artery. And this is his peripheral vasculature, and you can see that bifurcation disease and the SFA stenosis, and you can see that almost coming on to Lerish. And this is, of course, in a money shot, you can see a pinhole meatus of the left main stem coronary artery. So this is the classic situation of atherosclerosis. So there is an oxymoron in my heading saying aging rusty pipes. So this is the data from Korean War veterans in the 50s, the Autopsy series, with a mean age of 22 years. And you have got more than 3/4 of them has significant atherosclerotic vascular disease in the coronary arteries. And we know that it is an age-old disease. It's very, very old. And these two guys, Virchow and Rokitansky, quarreled quite a bit how and why atherosclerosis occurs, inflammations versus degeneration. Now we know it is mainly inflammation with the lipids playing a very central role. That picture that is shown here is actually a specimen from Rokitansky from the 19th century. They have stained and shown that it is actually inflammatory mediated by immune histochemical stains. So it's a major healthcare burden. Long-term decline in ASCVD has been happening in the Western countries that are stalled. By 2035, half the people will have ASCVD and north of $1 trillion. But more importantly for us, over 80% of the global CVD burden happens in low and middle income countries. This is what, again, yesterday we were sitting around in a round table and talking with Mohan and Sir and the rest of the people. What are the opportunities for research? We have a plenty of opportunity in our population to do this kind of research and find out now what exactly make us tick with coronary disease. The management, of course, the lifestyle change is the foundation. Lipid lowering is the cornerstone, along with management of 3 other main risk factors: smoking, hypertension, and diabetes mellitus. So still, I will just focus on lipids. We know the other risk factors, and the focus of the day. We moved away from the cholesterol numbers to intensity of statin therapy in 2013 ACCHA guideline, and that has been modified in 2018 and just 2 days ago. The United States Preventive Task Force recommendation just came out day before yesterday. Similarly, it is a little bit, I don't want to go into controversies, but similar. The recommendation is similar. Intimidating picture, but we will just dump it down to 4 statin benefit groups. Number 1, individuals with clinical atherosclerotic cardiovascular disease. They need high-intensity statin therapy, no question. So if somebody has an established disease, high-intensity statin. Number 2, if they don't have ASCVD, then you look at the primary target. That is a bad cholesterol, the LDL. If it is more than or equal to 190, high intensity statin. If these two things are not there, and the person is above 40 and below 75 years of age, then you see whether the person is a diabetic. And the LDL is, is at least modestly elevated above 70, then that person needs statin therapy. And last group is a number 4, that is where you don't have any of the first 3. Then you whip up your smartphone and take this app, the ASCVD Risk Calculator app. You will get it in any of your smartphones and plug in the numbers. The age, sex, and all the risk factors, blood pressure, cholesterol, history of diabetes, history of smoking, and you churn out a number. And that number in this case is 7.6%, as per the current guideline recommendation, with some changes which has been introduced by the USPSTF. I won't go into that. More than 7.5, you should start the patient on a statin, but with a detailed discussion with the patient what you are going to embark on. Because mind you, this is going to be a lifelong treatment that you are going to give. This is not a 2-week therapy that you give and then be done with. So the potential risk reduction you have to discuss in detail. We have to talk about what are the side effects that could be there. Other risk factor management is very, very important. You utilize that time to establish a relation with the patient and explain all those things. And still, the decision is not very clear. Then you have other means like calcium score or high sensitivity CRP or angle Beckel index or carotid intermedial thickness. All these things you can utilize if the person's risk profile is just below 7.5. You don't know whether to start statin. You do bring in all the other things into the picture, including family history, and then make a decision in discussion with the patient whether he should be put on a long-term statin therapy or not. So the calcium score is a very objective thing in this tool. We can really know anatomically what is happening. So it should not be done for a 28-year-old female coming to you with a chest pain. There is no point in doing a calcium score. And absolutely there is no point in doing calcium score in the patient I told you. Is multiple risk factors, classic symptom, there is no point in doing calcium score. So you should do calcium score in people who are intermediate risk, you're not very sure, and then you can start the patient on appropriate lipid lowering therapy. And the gradation of calcium score will be, 0 is normal. Of course, below 100 is low risk. 100 to 400 is moderate. Above 400, there is a risk of significant atherosclerotic vascular disease in that person, and you have to be more aggressive with them. Now, take a calcium score separately from the conventional risk factors. So you take about this, again, 65-year-old man who has got a high calcium score but no risk factors. On the other hand, you have got another 65-year-old man who has got multiple risk factors but 0 calcium score. How are they going to fare? And this was actually done as a population study from UCLA, Budoff and all. The basic takeaway is that if the individual has got high calcium score, more than 400, and no risk factors, they had a substantially more mortality rate compared to those with more than 2 risk factors and 0 calcium score. So if you have got risk factors and calcium score, that is the worst. But if you are asking about calcium score versus risk factors, probably no calcium is probably the better indicator. So we have to probably move away from the traditional risk assessment of multiple risk factors alone, but not totally, but this is a one good thought. For example, somebody is coming to you, multiple risk factors, I don't want any statin, so you recommend them based on the pooled cohort equation. But if the person doesn't want it, you can do a calcium score. If it is a middle-aged person and 0 calcium, probably, he may not have very additional benefit from it if the person doesn't want to take statins. So the medications, starting from over 30 years, we have various statins showing benefits. And also statins have shown to be anti-inflammatory by showing benefits in patients with the elevated C-reactive protein. And ezetimibe and hypertriglyceridemia with icosapent and ethyl. And this is a new enzymatic preparation, that is bempedoic acid. This is an enzyme, ATP citrate lyase, that upstream to the HMG coenzyme A reductase, that is actually statins. All these are newer medications that will help us reduce cholesterol. But whether we have outcome benefit, that is an important question that we have now with ezetimibe only after almost 30 years of no statin, other than statin, we didn't have any other medications actually. So anti-inflammatory drug, canakinumab, is another one that has shown to have some improvement, but it is not being used clinically. I'm just mentioning this because there's a lot of discussion about chelation therapy. I'm just mentioning there is no guideline recommendation for chelation therapy. It has shown some benefit in patients who are diabetic with the prior myocardial infarction, but ACC/AHA has not taken any position. There is a TAG2 trial is going on. Once the results out, only something will be told about that. The most important development that has happened in the past decade in clinical practice of lipid management is PCSK9 inhibitors. This monoclonal antibody, that is Paul Ehrlich, who got the Nobel Prize for immunology. We are talking about immunology here, so you can see on the left-hand side LDL receptors on the surface of hepatocytes. They actually get degraded by the PCSK9 enzyme. LDL cannot enter, cholesterol goes up, and you inhibit that enzyme, everything looks very good. Excellent results by Fourier trial, that is Evolocumab, Repatha, it is available in India also now. Alirocumab, both these things reduce cholesterol very significantly, and also it reduces outcomes. This is a newer one. This is lipase inhibition, angiopoietin-like 3 factor. So that is called evinacumab. And these trials have now focused on to the real villain in atherosclerotic vascular disease, that is Lp(a). So Lp(a) is the cornerstone and it's a real villain in multiple pathways through thrombogenesis and atherogenesis. It is a very, very highly atherogenic lipoprotein. It's an LDL moiety attached to ApoA to a disulfide link. Both Repatha and alirocumab, the PCSK9 inhibitors, reduce the levels of Lp(a), and through which it reduces the outcomes. It is very important for South Asians like us. So there is a lot of trials going on with the nice names like Masala, Sathi, Sath. Why in Asians there is increased risk of atherosclerotic vascular disease in the heart trial by Salim Yusuf, and it was known for a long time from Dr. Inas from 1992. And now ACC/AHA has come out with a position statement over the a couple of years ago, what are the risk factors and how to deal with atherosclerotic risk, especially high in South Asians. And again, focus turns around ApoA. So ApoA, the importance of ApoA is that it is not changed much by our lifestyle, exercise, diet, or nothing. It is closely linked to our genes. So that is the most important thing in the lipid management currently. So the Lpa, the high Lpa, South Asians in many studies have shown have relatively higher Lpa levels compared to the rest of the population. And there are some controversies regarding that. Some people say no. But by and large, the majority opinion is that Lpa is actually probably higher in South Asian population, and which is actually through which it mediates our unique susceptibility to atherosclerotic vascular disease. So this genetic variant study clearly showed that Lpa variants are associated with the high Lp(a), and that increases the risk of coronary disease. This is where youngsters, you are at the beginning of a dawn of a new era here. And I really envy you how you will be practicing medicine coming into the next decade of cardiovascular disease. So this is in 1998, Craig Mello from University of Massachusetts and Andrew Fire from Stanford discovered the short interfering RNA, and they got the Nobel Prize in 2006 for that. And that is already now we have, I used it over the last 3 months, I'm using this drug, inclisiran. This is a short interfering RNA which inhibits PCSK9 enzymes and durably reduces cholesterol level. You just one injection in 6 months. So it keeps the cholesterol down. This is another one. This is a different technology. This is an antisense oligonucleotide pelicarsen. This also reduces Lpa, selectively reduces Lpa. Inclisiran reduces LDL and Lpa, but this one reduces LPA. So another one is olpasiran, another short interfering RNA molecule. It actually just published the phase 1 trial. Already Amgen has announced that phase 2 results are actually very, very promising. So it will soon will be going within a year or two for FDA approval for this one also. The other one from JAMA, that is just 2 months ago, single ascending dose study of short interfering RNA SLN 360. So all these molecules can be very, very infrequently given. That's the importance of the compliance. And that is the importance for us because of the LPA and the South Asian population. And this was actually the biggest of all, winning 2010, the gene editing CRISPR, Emmanuel Charpentier and Jennifer Doudna from UC Berkeley and also from Max Planck Institute in Germany. This is the first time 2 ladies are together getting Nobel Prize in Science for the first time. And this is huge. And the way we practice various diseases will change with this. And we are talking about a heart disease vaccine now. This was a Nature article as a rhetorical question they were asking. But soon, the CRISPR editing showed PCSK9 lowered cholesterol in primates. And now we are taking it in the patients in New Zealand. The study started last week. Even when we are actually flying this high, we have to come down also, like polypill. Actually, we try to use polypill modulating multiple risk factors. This is Dr. Salim Yusuf's study last year. And this polypill, that is initial was in the primary prevention. This secondary prevention study was published yesterday in New England Journal of Medicine, showing benefit in patients with prior myocardial infarction. So, in summary, atherosclerotic vascular disease is essentially an inflammatory disease. And lifestyle change is the key. There is no getting away from it. So, you are not going to sit in your couch and get some vaccine and escape from it. So, statins are the mainstay, and other agents, PCSK9 is already here, and spectacular genetic manipulations are already emerging, especially targeting LPA. Comprehensive approach is exceedingly important. I will just come back to our patient finally. So this patient, of course, was a very high risk for surgery. He had a balloon and stent into the mainstem, and he's on PCSK9 inhibitors, and he's doing quite well without any stroke or anything. And that one vessel is taking care of his cerebral circulation as well as peripheral vasculature. No problems in 3 years. Doing very well. Thank you so much for the opportunity. Thank you very much, sir.
Thank you, Najib, for an excellent presentation and taking us through the various therapeutic options that are available to us now. Earlier, with dyslipidemias, we only had statins, and we never identified even though we identified lipoprotein little a. I think the first time I started hearing about lipoprotein little a was when Dr. Enas came down. The first study that Enas presented, where he showed that the South Asians in the US had a much higher prevalence of coronary artery disease. And that paved the way for this thing. And then he clearly said that lipoprotein little a was the villain. But unfortunately, we never had any drugs specifically targeting lipoprotein little a, and we are only targeting with statins. So I think these are all new developments. The other thing with what you said is the vaccine. Probably if you can develop a vaccine, that may also go a long way to prevent. What we need to understand is prevention and not treatment is the way forward. Correct. For atherosclerotic vascular disease. There is no other way. I think any questions from the audience, any comments or questions from the audience? Citus?
No. You are right, sir. The ratio of ApoB and ApoAI, that is the ratio. And ApoA in itself is also a strongly atherogenic if you look at the molecular mechanisms, how it acts. It's a clinical association of ApoB and ApoAI ratio that is important. But if you mechanistically, if you look at it, it's ApoA is very, very important. And the vaccine, it's not actually a vaccine. This is just once in a lifetime infusion of CRISPR. That once in a lifetime infusion will actually fix the cholesterol levels. So that's what Shekhar Kadireshan, actually the Varu Therapeutics CEO, he was a cardiologist, Mass General, is proposing. It is why I said this thing, and even though it looks very high funda for us, if we can bring it actually, if we look at the compliance, our population, if you can think about something that we can affordable and give it to the population just once, and it will be huge. So that is where we want our youngsters molecular mechanism to develop, and then we can give it in a affordable fashion to all of us. We start looking, this is one very important question that you're asking, because standardization is extremely important. That is one of the problems that we have here. So I ask all the biochemists here, including my sister, maybe, they should all standardize how you measure LPA. Routinely, it is not measured in the US. Now it is almost routinely, at least in the younger people, we do measure LPA routinely. The reason, as I said, there is nothing to do. What you do after looking at it? There is nothing to do. But now we have. Now, and things will be changing, very dramatically changing.
I think the last comment, yes.
Sir, just one question. Thank you, sir, for that talk. We are prescribing, a lot of doctors, including me, are prescribing vitamin D left and right without even checking the vitamin D levels. So
no data for absolutely no data. Absolutely no data.
No data that they prospect.
No, nothing.
Excellent presentation. Thank you very much.
Yeah.
Now my question is that you said on statin therapy is started. It is permanent and lifelong. Suppose I take statin and my cholesterol is 260 or so, and during a course of time, maybe after 6 months, it's coming down to 190, 140. And I what do you think of stopping?
No, the one thing, nothing is written in stone here. I mean, statin is meant to be long term, that's correct. But if it is bothering you so much, we can cut back on the dose. We can change it into another statin and then see if it is relieving your symptoms. But the other thing is more important. You are not going to reduce the statin just because your cholesterol dropped. You should not. You should keep on it. And the idea is actually for long term. Keeping cholesterol down for a few months is not going to change your atherosclerotic profile at all. So keep on it. That is what actually 2013 changed. That's why I said we are not looking at the numbers, we are looking at the intensity of statin therapy. That has to be very clear. That is what the task force, that is what they're promoting, is that use intensity of either high intensity or moderate intensity statin. Use that initial, that 4 group I said to start the therapy and then maintain it. Depending upon the patient's tolerability, you may want to change it. That's a different thing, but not based on the cholesterol numbers. You want to, if at all, there are other guidelines to go more higher, adding other things, like all the things I said, but nothing to just pull back on the statin just based on the numbers alone. But based on symptom, you might do. Side effect, you may do. But other than that, just keep on it. That's what it is, yeah.
Lastly, I am a surgeon, but I have seen that mostly we are blaming cholesterol unnecessary. It is an essential brick of the bodybuilders. And when is the fact that 20% of only diet contributes? The rest is manufactured in liver. So what about all the diet restrictions?
It's a big topic to talk about it. I know where it is coming from, especially the egg controversy and all. But it is very important. One thing I will just tell you: excessive cholesterol. Taking an egg a day, including yolk, it's not a problem. It's not a problem. But the thing is, excessive, it is a problem, and calories are more of a problem.
Exactly.
If you have higher calorie, that will get converted. So the egg controversy, I will just tell this much. If you take an egg a day, that's fine. But don't keep on eating egg. It is bad if you are going to take the egg yolk. Egg white, any amount you can take, no problem. Any amount of egg white you can take, no problems.
Good luck.
I just needed to say that just before concluding, the last sentence is all that Najib talked. I think Sri Shiva Shankaran will agree with me that the target population who should look at is from the age 25 to 35. Because there is no point the older age group going after all this. This is for the younger generation, because if you want to prevent cardiovascular disease or any vascular disease, you please start. Have your lipids checked, your blood pressure checked, and your lifestyle change from the age of 25. Not at the age of 45, 50. You look at Dr. Shiva Shankaran.
Exactly. We missed this talk yesterday.
No, that's true. No, I'm giving a general advice because we always look at people who come with a established vascular disease. We need to change our ideas. We need to go back earlier and start preventing earlier.
Yeah, exactly.
I have one question. So, Dr. Najib, you said we are moving away from the treat to target approach in terms of LDL numbers. Can it be applied to patients with diabetes? Because our endocrine guidelines still...
That's precisely, and I forgot that Nisha is here. So endocrine guidelines actually are more stricter. So they want it really low. I mean, the multiple high-risk patients, they want the LDL to be below 55. So what I meant to say was, we did not have, what will you give? If you give 80 milligram atorvastatin and still your LDL is high, previously, in 2013, we did not have. Now we have PCSK9. If it is above 70, you give PCSK9 to bring it below 70. For that, it is useful. So use the number to drive it down further. Don't use the number to release the, take off the pedal. That you don't do it. So if it is a high-risk person, use that actually to intensify a lipid-lowering therapy with the ones that that outcomes are changed. The ones that we know are actually the ones I mentioned about. Basically, it is LDL reduction by statins plus PCSK9 and little bit maybe ezetimibe and maybe icosap and detail, but the big ticket items are these two. And endocrinologists it's extremely important in diabetics and those with the CKD and PAD. Yeah.
The last sentence is the Lipid Association of India. For the Lipid Association of India, the target LDL for high risk, extremely high risk patients is 30 milligram of LDL. It is far lower than what the Americans have said. So I just wanted to conclude with that. Thank you, Najib, for an excellent session. We all enjoyed it. Thank you.
Thank you. Thank you. I mentioned, yeah. Yeah, yes, yes. Nextly told, yes.
We request the chairperson to hand over the certificate of appreciation to the speaker, Dr. Najib Usman. We request Dr. Matthew Thomas to hand over a certificate of appreciation to the chairperson, Dr. Venugopal K.
Delegates, please note the following vehicles are causing inconvenience to traffic: KL01CU 9766, KL01BJ 2153, KL82 2030, KL01CT 6850, KL01AU 7840.
We are moving on to the next session, Professor Roy Charlie oration. The Professor Roy Charlie Award has been conferred to Professor Thomas Matthew.
What does Professor Roy Charlie mean to Government Medical College Trivandrum? He was an alumni of this. He was an alumni of this college. In fact, when we talked today morning to Professor Pichumani, who is delivering his lecture tomorrow, he was very emotional. He said, because he is coming on Zoom. So he said he very much wanted to come for this convention because Professor Roy Charlie was his roommate. So that is the amount of emotions. That's a degree of emotion Professor Roy Charlie has among his friends and colleagues. Second, our institutions, he was instrumental in having the first renal transplantation along with our orator, Professor Thomas Matthew, in 1986. Later, when we started renal transplant in Trivandrum, for the first 5 cases, he was here to mentor our professors to do that. So that is the amount of involvement Professor Roy Charlie has regarding government medical. And later in 2016, when we conducted an updates in transplantation along with our annual convention, he was very happy to come over and talk to us about outcomes of renal transplantation in various centers. So he compared the outcomes in various centers and gave us an excellent thing. And 2 years ago, he came and received the Distinguished Alumni Award. So that was he was always happy to come back to his alma mater. And so today we are now here to hear the oration in his name.
We invite the Vice Chancellor, Dr. Mohanan Kundumal, Dr. M.K.C. Nair, the Chairpersons, Professor Kashi Vishweshwaran, and Professor Kim J. Maman onto the dais. We also request Dr. Thomas Matthew to come onto the stage. We humbly request Dr. Mohanan Kundumal to adorn the medallion on Dr. Thomas Matthew. We request Dr. M.K.C. Nair to present the scroll. We now invite the chairpersons, Dr. Kashi Vishweshwaran and Dr. Kim J. Maman, to take the stage. Thank you.
Good afternoon. The memory of Dr. Roy Chali brings in very nostalgic memories, because in the early 1998, when we started transplantation first in Kerala, in Trivandrum Medical College, he was the one who came and mentored and then started the transplantation with his students, who were by the time professors of nephrology, professors of urology. He had been here for about, he used to come on his own even after his retirement, and he refused to take any travel expenses or anything. He just came on his own, and those days we were only having the two types of cars, Ambassador and Fiat, and he used to come in his Ford, driving all the way night, and then he would come and do the transplantation and with a smiling face say, get back. I can never forget his smiling face and his interaction with all the juniors. Professor Roy Chali was born in 1937, I believe in Malaysia. Then he migrated and he did his schooling in Mulanturuthi near Ernakulam, did his MBBS from here 1960, MS also from here, and then MCH Urology in 1968 from All India Institute. I remember him as an undergraduate student for a short while, a few months he was in Kottayam, then he moved over to Calicut, set up the department, which has now become a very important department of urology in Calicut. He was later on in Baby Memorial Hospital, and I feel jealous of Thomas Matthew because he had such an excellent urologist to work with. And Dr. Thomas Matthew, a year senior to me in medical college, he is now senior consultant in nephrology in Baby Memorial, formerly founder and head of the department of nephrology in Medical College Calicut, superintendent of Medical College Calicut. He is awarded a number of fellowships, as you can see from the slide here, FISN, FRCP, and Academic Excellence Award, Best Doctor Award of Kerala. In addition to that, he is a very good speaker, and the topic that he has chosen for this oration is the other side of kidney disease. We know only one side of the kidney disease, that is developing acute nephritis, acute renal failure, and recovering, or chronic kidney disease, going on to dialysis or transplantation. And knowing him very well over the last so many years, we don't know what he is going to really talk about. He is going to talk something surprising, and I would hand over to Kim for a few words. After that, Thomas Matthew will surprise us with this talk. Thank you.
Just a word about Professor Roy Chali. He was my examiner for MCH, And again, when he was president of the Urology Society of India, I was the secretary of the Society of India. I have learned so many things from him, and he has also come and visited me at my institution at Ludhiana. He is one of the greatest teachers this country has seen in urology. And apart from being a good surgeon, a very versatile craftsman, he has also trained so many urologists in Calicut who are adorned good positions all over the country. So he is a teacher of teachers. Coming to Professor Thomas Matthew, he has been trained at PGI, and I think he is the first DM from PGI trained by Professor Chugh. And he is one of the persons who was instrumental in starting renal transplantation along with Professor Roy Charlie at Calicut. And Dr. Thomas Matthew is one of the renowned nephrologists in our country. And I've had a special relationship with him because his brother, Dr. Abraham Thomas, who is a plastic surgeon, internationally known plastic surgeon, was my mentor, and I had worked with him. And I have met numerous occasions to meet and interact with Dr. Thomas Matthew. Over to Dr. Thomas Matthew, looking forward to a very brilliant oration.
Thank you. Respected chairpersons, my real colleagues, Dr. Kashi, Dr. Kim, the distinguished guests in the audience, friends. I consider it a privilege and a great honor to have been given the position to do the first Roy Charlie oration in this prestigious institution during the Platinum Jubilee celebration. I really thank Dr. Panikar, Dr. Vasudevan, Dr. Indu for having selected me for this oration. You might wonder as to why I chose the subject of the other side of renal disease. I know this crowd hardly one nephrologist, Dr. Kashi, because speaking about nephrology will go above our head, and you won't appreciate what the intricacies of nephrology if I speak. So I thought I'll talk in general what I have learned in nephrology over the last 50 years in dealing patients. You are doctors, you have ENT specialists, you have cardiologists, you have orthopedicians, you have gynecologists, but invariably you will be seeing patients having kidney disease. But how to look after them? Because it is our job that the kidney disease patients have to be looked after. Now 37% of the population have chronic kidney disease in our state. And the budding people, budding youngsters, more than 20% are diabetics. More than 16% are hypertensive. Invariably after 10, 15 years, they are all going to have chronic kidney disease. So we should know the other side of chronic kidney disease. I bring you greetings from Calicut. You know, Calicut is, can you switch off the lights, please? Calicut is a city, beautiful, full of halwas and full of biryani. Anybody who has come to Calicut will want to come to Calicut again and again because of biryani. And you have beautiful, the urus built in Bepur, which is exported to the Middle East for the sheikhs to use. So the Calicut has been time immemorial a great city of Kerala, and we are happy we are able to work in this institution with Professor Roy Charlie. Now, Professor Roy Charlie, as already mentioned, was a legend. He was a gentle giant in the field of urology. As we heard, his basic education was in Malaysia, his parents were there, and then he went on to become tutor in surgery, then assistant professor of surgery, then assistant professor of urology, and developed a department of urology, and retired in 1992. And from 1992 onwards, for almost 32 years, he was working in a private hospital in Calicut. I have retired in 1997, and till the last day of his death, I was along with him. He was my close friend and benefactor, as well as a guide in how to organize a department and how to organize various things in the department. So Calicut Medical College is proud to be the first institution to have renal transplantation. the first center to have renal transplantation, and the first center to have a large dialysis setup for the first time in Kerala state. And Professor Roy Chali developed a full-fledged department of urology and started the postgraduate course in urology, and first transplant, as I mentioned, and outstanding teacher, and he was the last word in urology in our state for a long time. And his hands were like God's own hands, just like we call God's own country. Dr. Roy Chali's hand, the moment he touches the patient becomes, he is better. So that was his reputation in Calicut, in Malabar. Now from Calicut Medical College, we started, along with the Dr. Roy Chali's help, the full-fledged dialysis. We started with a very primitive dialysis machine as we got donated from the US, and then we went on to make newer and newer machines, and I am proud and happy to tell you that every nook and corner of our state now has dialysis facilities. Patients with kidney disease don't have to go to Chennai or Madurai or any other place for any treatment. They are available in our own state because of the initial effort which we all have put in. Dr. Kashi has put in his effort in Kottayam and Trivandrum. The people have been there, and we have done a lot of work on this so that every nook and corner, a patient with chronic kidney disease gets treatment which started from Calicut. I am proud to say that. So likewise, the transplantation has gone right from Calicut in 1985, and now everybody does transplant. Every institution has got transplant, and now we are going to do the transplant across ABO barrier. Now, the Professor Roy Chali has to be mentioned again because this is his oration. He has had many orations, including Dr. Raghavachari oration, many awards as eminent doctor of Kerala State, Urology Gold Medal, and so Urology Society's award, and he was examiner in MCH. So suddenly he passed away in 14th of May 2022. May his soul rest in peace, and his legacy let it continue. Now the kidneys are very important organs. I will say it's amazing organs of the body, amazing organs. And it has got very many functions, as we all know, we teach in physiology. And I want to mention to you two things. One is the clotho-protein. Clotho-protein, I will come to that later. For longevity, long life, clotho-protein has to be done. If the kidneys are damaged, the life is shortened. And then the renal tubules. Renal tubules are fantastic, and which we do not know much. You know, Clotho is a goddess. There are 3 goddesses for life, who spins life as far as the Greek mythology is concerned. And Clotho is the person who will cut the life of the individual. The Greeks believed that Clotho will cut. So there is a protein in the kidney coming from the tubules, which is called the clotho-protein, and the protein will help to maintain the stability of the chromosomes so that the telomeres will not shorten fast. That's a new invention, and it has been found out. And then you have the tubules. The tubules of Henle. The tubules of Henle is fantastic, unimaginable functions. The descending limb, the loop, the ascending limb, with collecting all different functions, not yet fully known that whose functions are there. And multiple functions because of the ability of the renal tubules. How God created the tubules, I do not know. Still we do not know the wonder happening in our kidneys every second of the body. How it is concentrating, how it is diluting. 180 liters of urine we would have passed if there were no tubules. 180 liters. Out of the 180 liters, all are reabsorbed, except 1.5 comes out of the urine. The fantastic tubules to be remembered. And now we find that the tubules are made use in the treatment of diabetes. The latest drugs in diabetes, SGL2 receptor blocker, is acting on the tubules to send away all the glucose in the body out into the urine so that the diabetics become all right. Without giving a drug which will act on the insulin or the muscle or anything, this new drug, as we all know right now, dapagliflozin, will prevent the glucose from getting reabsorbed. So fantastic how the nature has been given us information as to how it has to be prevented from getting absorbed. So it's just like looking at the galaxy. The functions of the tubules are fantastic. So many things we do not know, yet more to come. Now, we all know that the serum creatinine is a very dangerous situation. But we should remember that serum creatinine remains normal till the glomerular filtration rate comes to less than 50. So if a person's creatinine is 1.1, 1.2, doesn't mean that he is perfectly normal. He can still be having a chronic kidney disease. That has to be remembered. A creatinine of 1.5 is definitely more than 50% of kidney function lost situation. So patients coming to physicians for consultation from the surgery department saying that this creatinine is slightly high, you must see that if it is slightly high, it is very bad for the individual. The drug has to be monitored and his treatment schedule has to be monitored. So the kidney, as far as is concerned, aging takes place in the kidney as person ages. A person's age, suppose 75, his kidneys are also 75. Suppose the patient has got 20 years of diabetes, you have to add that 20 also. So his age will be 95 as far as the kidney is concerned. If they have got hypertension also, add those years also into the age of the individual. So it's another 20 years. That means more than 100 years for the kidney. The poor kidney is suffering because of diabetes and hypertension. So age is a very bad factor for the kidney. A person with 70 years having a creatinine of 1.7 doesn't mean that he has got a kidney disease, but his kidneys are aged. So you have to adjust the dose of many drugs. So it has to be remembered. So GFR in aging falls down as years go by. Glomerular filtration rate declines with age by approximately 1 ml per minute per square meter, beginning the third decade of life. At 70 years of age, the glomerular filtration is only 40, less than 40. So the kidney in aging becomes so much of structural, microscopic, as well as functional change. One should remember, it is not a disease. It is an effect of aging. It has to be remembered. Now, high creatinine is a problem now. Any patient comes to the hospital, Sare, creatinine koodalana. This is what they say, creatinine koodalana. Creatinine can be high because of kidney disease, but without kidney disease. That you have to remember. High protein intake, that some people take 4 to 6 eggs a day, especially those people who go to the gym and bodybuilders, sportsmen. It produces high creatinine. Excess increase of cooked meat, red meat, and intense exercise. Drugs like cimetidine, very common drug, trimethoprim, again a common drug, then steroids, all these can increase the creatinine value without a renal disease. Creatinine production in the body is high, so that's not completely removed. And of course, it interferes with lab tests, presence of chromogen in blood like acetone, acetaldehyde, fasting lipemia, hemolysis, all will increase the creatinine. Another important problem with the patients now is microalbumin. They'll say, microalbumin is there. Lab will test and will say microalbumin. It is a forerunner of kidney disease, forerunner of cerebrovascular disease, but without that, microalbumin can also occur. And obesity can produce microalbuminuria. Metabolic syndrome, hypertension, orthostatic proteinuria, all this can lead on and start with the microalbuminuria. But it's a risk for cardiovascular morbidity and renal disease. It indicates pre-diabetic states and predicts an acute respiratory failure in multi-organ failure and overall morbidity in patients in ICU. The ICU patient develops microproteinuria. It predicts that he can go into complete cardiac, renal, as well as respiratory failure. Frothy urine is again another very important problem, frothy urine. Frothy urine could be renal disease, might not be renal disease, but you have to be careful. But frothy urine can happen without kidney disease in a full bladder, and if the person voids very fast. A high-speed urine output will produce froth in the commode. And very concentrated urine also can produce froth. If there is a retrograde ejaculation, it can produce froth in the urine. Early onset of amyloidosis and intake of pyridium, intake of SGL2 receptor blocker, and it may be also a factor in the toilet. The toilet cleaning solution will have some soapy substance in that. If a person passes urine, always there will be froth in the urine. It's not renal disease. The cadmium toxicity, multiple myeloma, phospholipids, foam cells, and patients with cholestasis all can have froth in the urine. Now, another major problem which we are facing every day, every clinician, is obesity. Patient with obesity is a killer. Obesity is a silent killer like hypertension or diabetes. So 30% of the population are obese. It's a complex disease involving an excessive amount of body fat. It's a medical problem that increases the risk of other diseases and health problems in heart disease, diabetes, hypertension, dyslipidemia, certain cancers, metabolic syndrome, and even kidney disease. Body mass index, we all know. Body mass index is high. we have to tell the patient that they have to reduce their weight by diet as well as exercise. The best is to examine the circumference of the stomach at the level of the umbilicus. With more than 90 is bad for the male, and more than 80 is bad for the female. So that has to be remembered. Measurement of the neck is very, very important. The neck circumference is again a marker of chronic kidney disease, chronic liver disease, chronic heart disease. If it is more than 40 centimeters in an adult male or more than 30 in a female is a problem. So obesity is rampant in our population, rampant. And obesity produces so much complication. And the renal problem is very rampant, which we all know. Patients develop focal segmental sclerosis and glomerular sclerosis, and they die. So any patient, whether it's a orthopedic problem or a gynec, if they're obese, we have to tell them about their obesity and tell them that it's going to be dangerous as years go by. So in diabetes, in hypertension, 1 in 3 invariably will go into chronic kidney disease. So diabetes, as we all know, is again a silent killer. Invariably, it reduces the lifespan and produces a problem for all organs of the body, especially the kidneys, blood vessels, and the nervous system. Diet has been very bad in Kerala state of late. Very bad. Very bad in the sense they consume large calories of diet. They eat fish, they eat fish, they eat meat, they take so much of rice. Altogether, the major food item becomes carbohydrate. So because of that, everything goes up, like the lipoproteins, that the cholesterol, everything goes high, and the patient becomes obese, develops atherosclerosis, and the lifespan becomes less and less. So an important thing is to send the message of the food plate in diabetes. Food plate, we all know 50% of vegetables and 25% carbohydrate, 25% protein. This has to be remembered. For patients with diabetes, their blood pressure as well as the blood sugar has to be well controlled. Blood sugar fasting should be definitely less than 100, and the postprandial should be less than 160. BP should be controlled with 2, 3, 4 drugs. It should be less than 130/80. Lipids to be controlled. Uric acid level to be controlled. Patient with hypertension, again, irrespective of what specialty we practice, see that the BP is controlled definitely. Another important factor in chronic kidney disease, which is the other side of the kidney, is hyperuricemia. Very often forgotten, but of late it is given much importance. High uric acid is dangerous to the body, dangerous to the kidneys. So control the uric acid level by diet, protein restriction, exercise, and then give drugs if required. ICU care. Patients with ICU has been found that they invariably go into chronic kidney disease. Why? Because they all go into acute kidney injury, and acute kidney injury is a forerunner of chronic kidney disease. So any patient in ICU should be followed up very carefully so that they should not go into chronic kidney disease. Acute kidney injury to chronic kidney injury is a continuous process. It's a continuous process. You might leave the patient from the ICU, but you might not be following them. After 5, 6 years, they'll go to the nephrologist with CKD. So ICU care has to be very monitored. If there is a renal dysfunction, it has to be followed up. So acute kidney injury goes into chronic injury as a continuous process. So more than 1 in 7 individuals are having chronic kidney disease all over the world. Progresses. And 1 in 5 adults over the age of 65 has chronic kidney disease. And 2 in 5 people who are above the age of 75 also have chronic kidney disease. So the impact of chronic disease is very high, and more than 1 in 7, 1 in 10 people have chronic disease. Age, as already mentioned. Then, very important thing to understand now is that there's a mysterious disease going around all over the world. Mysterious disease. It is occurring in many parts of the world, which is unrelated to known factors like diabetes or hypertension. It affects the young people, middle-aged people living in the temperate climate and the tropical areas. In the tropical areas of the world, there's an unknown disease. It's called CKDU. And in mysterious disease, it's a threat to the health of our world. And it is called CKDU because there is no cause made out. And this kidney disease of unknown or uncertain cause affects the marginalized agricultural workers in US, in Africa, in India, in Ceylon, well established. Currently, it occurs chiefly in Sri Lanka and in Central America. And throughout, the additional spots are there. And in America, it's called mesonephric nephropathy. And in Sri Lanka, it's called Sri Lankan nephropathy. And we have the disease in Tamil Nadu, in Telangana. It is called the Mesoamerican nephropathy. And in Telangana, you have the Sri Lankan nephropathy, then Uddanam nephropathy. We do not know the cause. The people working in farm lands, in agriculture workers, whether it's coming from water or some food item, we do not know. So Uddanam nephropathy. And you have Thodai Mandalam nephropathy near Pondicherry. So much of investigation is going on, but the cause is not known. But it could be environmental factors or it could be lifestyle factors, not yet decided. But should remember that newer and newer diseases are coming into our country, which we do not know why it is so, other than coronavirus. So unusual symptoms of kidney disease of unknown etiology doesn't have hypertension or diabetes. Young people become sick all on a sudden and the whole family becomes abnormal. So you have the Mesoamerican nephropathy, you have the nephropathy in Egypt, you have it in African areas, and you have in India, in Punjab it is there, and you have in Sri Lanka, you have in Pondicherry as well as in Telangana. So nephrogenetics is a very important thing to remember. Genetics has become very important in nephrology now. Many diseases which run in family. About 30% of chronic kidney disease patients have a family history. So finding out is it genetic is very important in proper diagnosis and treatment. If it is found to be genetic, there's no need to give all these steroids and other materials. It wouldn't do any good. And if it is genetic, about transplantation, the donor of the same family member should not be a suitable candidate for the transplantation. So genetically, we know that IgA nephropathy, focal segmental sclerosis, steroid-resistant nephrotic syndrome, then Fabry's disease, Alport disease, membranous disease, membranous proliferative disease, all they have genetic background. And find out how its genetic background is. You can get it estimated by the genetic testing test. It's all available now in our market because we have RENA site, kidney gene panel is available, and we have med genome is available. It will tell whether a family member also has the same gene. Then becomes difficult to manage. But unnecessary treatment, unnecessary investigation, unnecessary biopsies can be avoided. So clinical benefits are there in genetic testing, where accurate diagnosis can be made, and proper treatment can be administered, and proper advice can be given to the family regarding the further management of the patient. So another important side speciality in kidney is onconephrology. Onconephrology has come, the kidney disease cancer-related as well as treatment-related. So an American Society of Onconephrology has already started last year. So it's a boon for patients with chronic kidney disease in diabetes, in cancer therapy as well as cancer treatment. So there are so many myths about kidney disease. One should know that myths about kidney disease. Kidney disease is a rare condition. It's not a rare condition. If you feel fine, there is no chance of your kidneys are diseased. No. Because up to 50% of kidney damage, no symptom will be there, no sign will be there. And testing kidney disease is a long and costly process. No. A simple urine examination is sufficient. If you are at risk of kidney disease, there's nothing you can do about it. That's again a false statement. You can definitely look after them. So like that, there are so many myths we should realize and understand. It's all we have learned during the last 50 years of day-to-day patient practice in collaboration with the urology and nephrology and general physicians and the surgeons. Patients are high risk of kidney disease, above 65 years, obese patients, hypertensive. So there's a new era in chronic kidney disease management. Thank you very much for the patient listening.
We humbly request Dr. K.P. Haridas to present our certificate of appreciation to the chairpersons. Dr. Kashi Vishweshwaran and Dr. Kim J. Maman.
Yes, thank you, Matthew. You really showed the other side of kidney disease, renal disease in general. What I want to emphasize in particular, whatever he mentioned, is if you look at this hall, the front half of the hall is almost, or most of them, except the people sitting in the compere desk, are over 70, and the back hall is less than 20. Anyway, the point is that the dose of drugs that we are going to administer to elderly people must be nearly pediatric dose. The most of the problems that we've come across in the ICU is that old people are admitted and they are given the same dose as an adult. We are not adults, we are almost like children. So that is something that we have to remember. It's a practical point which he has highlighted. Thank you, Thomas Matthew, for a wonderful oration. As it's an oration, there are no questions allowed, and we close the session.
What picture we remember about Professor Roy Kelly, we said about 5 cases he was here. Actually, the second case, when he was there, those were not it was a double vessel disease, double vessel kidney. And suddenly, when it was harvested, it was double vessel. So, Roy Kelly sir took the kidney, very calmly went, give me a place where I can work, and settled down to do brain surgery when he reconnected the 2 vessels and went on as nothing unusual. That is the greatness of the man. No sign of tension, very, very simple and quick and fast in his work.
We humbly request Dr. K.P. Haridas to present our certificate of appreciation to the chairpersons, Dr. Kashi Vishweshwaran and Dr. Kim J. Maman. The upcoming session is Dr. V.C. Matthew Roy's session, followed by discussion on medical management of obesity. The session will be chaired by Professor Dr. Aruna R. and Dr. Abhilash Nair. Inviting the chairpersons onto the dais.
Shall we start? Good afternoon and thank you. I am happy and honored to be chairing this session in memory of our beloved teacher, Dr. V.C. Matthew Roy. I belong to one of the last batches of students who were fortunate enough to be taught by him. He was a pioneer of sorts. He was first postgraduate in medicine from Trivandrum Medical College, the first person to start an endocrinology department, the first person to start a diabetic clinic, then first secretary of API Kerala chapter, and also he was the first one to really think about death auditing and presented a paper based on that. In addition to that, he was a ready reckoner. We could always ask him about rare disorders and syndromes and metabolic disorders. An astute clinician. I remember the evening rounds of Dr. Matthew Roy. People used to run to listen to that, and it would carry late into midnight, and it was full of information. And he is one person who was never biased. No gender bias, no bias. Whether it's an undergraduate or a postgraduate, MD medicine or Dip B medicine, medico or non-medico, he was always ready to teach with passion. He's a kind person and a great soul. So he was a benchmark for all the teachers in medicine all over the state, especially in, and also in Trivandrum Medical College. Coming to the topic today, it's of contemporary relevance, obesity. I'm here to chair a session. On in memory of my teacher, and the person who is speaking is my student. So I'm doubly happy, Nisha. Over to Abhilash for introducing Dr. Nisha.
Thank you, organizers, for inviting me. And actually, it's an honor to be part of this program. Again, the session which I have been invited is also so apt because it is P.C. Matthew Roy sir who started the department and created a post of lecturer in endocrinology, which later became an assistant professor post, and I am currently working in that. I got employment because of him. And now, regarding the topic, we are all facing this problem of obesity, which how to manage it. It's a real headache for each and every physician, and especially for us in endocrinology. To discuss the topic, we have Dr. Nisha Nigil Haroon, who is an assistant professor of endocrinology at the Northern Ontario School of Medicine. She is a consultant of the Scientific Advisory Council, and she is the recipient of clinical research fellow. She is a clinical research fellow of Women's College Research Institute, Toronto, and recipient of the PSI Graham Farquharson Knowledge Translation Fellowship, and also received the Early Investigator Award in Bone Health from USA. And she has also been selected for the 18th Fellows Forum of Metabolic Bone Diseases in USA, and member of the Journal Editorial Board of International Diabetes and Technology. And she also is very active in social issues relating to our medical graduates living abroad. And she's the co-chair of the annual convention of the Association of Medical Graduates, chairperson of AKMG, and president of the Association of Medical Graduates of Calicut origin in Canada. She is a regular speaker for many of our endocrine conferences in India and in Kerala. And we have also heard her previously in the TMC Alumni Association meetings online during the COVID period. Thank you, ma'am. Please.
Thank you very much, Dr. Abhilash and Dr. Aruna Madam, for the kind introduction. And I think Dr. Matthew Thomas left. He's really my mentor and guru in the field of endocrinology. And it's a great honor to be presenting Dr. Roy's oration. And I would like to also thank Dr. John Panikar sir, Vasudevan Putti sir, Indu madam, Lakshmi madam, and everybody from the organizing committee for all their dedication towards the Alumni Association activities. Okay, before we the timer is already running. Anyway, so can we get a show of hands, please? How many of you in the audience have prescribed a weight loss medication? Okay, so we really have, I really have some data to present. And I think I just saw 4 or 5 hands. So moving on to the slides, most of what I'm presenting will be based on Obesity Canada guidelines. It's a very famous established guidelines endorsed by various endocrine organizations worldwide. So I'll stick to Obesity Canada guidelines, mostly evidence-based. And this is my disclosure. And objectives, so we still have barriers, and we did see my background slides. Actually, they were presented by Professor Thomas Matthew. He had, I guess, like 5 or 6 slides on obesity. So right now, we do have evidence-based therapeutics, so I'll be discussing those agents. And again, our current understanding is that obesity is a chronic, relapsing, multifactorial, and heterogeneous disease. So we'll come to the details of this. Heterogeneity, because we are seeing a heterogeneity in response to weight loss. No matter what intervention we do, this is still a challenge. And again, the cause is multifactorial, as in any disease. So genetic factors, environmental factors, so, and also adipogenic food, calorie-dense diet, which we already discussed this afternoon. Genetic factors, so now we do have a great understanding about the genetic factors. So let's stop blaming patients about their diet and lifestyle. There's more to this. It's not just diet alone, or it's not just exercise alone. And then there are complex neuropathological hormone interactions mediating this disease. So it's more than diet or exercise. And increasingly, a lot of our patients are on medications that can cause weight gain. So when you address treatment or precipitating factors, always look at various medications that can cause weight gain, including SSRIs and antipsychotics and even insulin or sulfonylurea. Looking at Indian data, there are some studies looking at very high prevalence, not surprisingly. Initial data showing that more obesity in urban and educated individuals, but there is this projection coming out, published in PLOS One, saying that the obesity prevalence is exponentially rising. It's another pandemic in the making, which is already happening, and prevalence is exponentially rising, especially in rural residents and older older Indians. So given the lifespan extension. So, and we all know the metabolic and vascular complications of obesity, but this is one important aspect. There's a recent publication from 2022. Obesity has been attributed as a cause for preventable cancer. So if you look at smoking, alcohol, high BMI comes next, along with other occupational and environmental risk factors. But what are we doing in terms of managing this crisis? Often we ourselves are not educated or equipped. We don't have time to discuss the weight intervention. We just tell patients, go lose some weight, eat a healthy diet, and the conversation ends there. Several reasons, and sometimes we are also facing this crisis called therapeutic inertia. We don't discuss weight management with patients always. We have to come up with specific tailored weight management, and terminology also is very cautious because sometimes there's stigma and embarrassment from patient side. So we have to be cautious when discussing weight. And another crisis that we see is the significant amount of weight regain after any intervention. So I think Dr. Vinod Menon is going to talk about weight loss surgery. Again, I mentioned the barriers. We need to understand these things from patient perspective as well, and address the systemic barriers. Often we see patients are left to navigate a complex landscape of weight loss products and services. We traditionally tend to shy away from social media and are not influencers, but that space is taken up by all sorts of pseudoscience and other healthcare work, or I would say social media influencers, including celebrities propagating misinformation towards weight loss interventions. And they are often dealt with unrealistic and unsustainable weight loss goals. Again, there is new interest on identifying subtypes of obesity. This is interesting based on the satiety studies, hunger studies, and also gastric emptying studies. So this is why we understand more why a subset of patients do not respond to any kind of intervention, or certain patients respond to only a certain type of intervention. So now we have the ability to understand that subtype classification. Again, treatment is based on medical nutrition therapy, which we're all familiar through guidelines and also through WhatsApp forwards, and then pharmacotherapy, surgery, and physical activity. So I'm going to skip this slide in the interest of time. So there's a lot of advocacy going on to educate physicians and empower them with tools to advocate towards weight loss management. Coming to treatment, we have two aspects of this, weight loss and weight loss maintenance. First part is easy, and we need to have targeted therapies and non-pharmacological interventions that can lead to long-term reduction in calorie intake and long-term adherence to a healthy eating pattern. Benefits in the diabetes world, even with weight loss, like even a 5% weight loss, you see a 0.5 reduction in A1C, 5 millimeter reduction in blood pressure, and improvement in lipid parameters. But if you look at, in general, up to 10% weight loss, we can prevent diabetes, prolong diabetes remission state, and also other metabolic parameters can be improved with weight loss. So cutoffs, we did discuss BMI just now, but remember, in South Asians, the cutoff is much lower. It's not 30, it's 27. And also, we have to look at waist circumference, because most of our patients are not obese. They are based on the BMI of 30. They are obese based on the BMI of 25 to 27 and about 27. So we have to look at different cutoffs. And waist circumference, make sure that we measure or encourage patients to check waist circumference at home so that we can follow these metrics. Now, looking at weight loss interventions, any intervention will work in combination, synergistically, so we have to have medication and lifestyle, plus combined intervention. We just need 5% for meaningful clinical outcomes, but up to 15 to 20% weight reduction can actually cause diabetes remission. Now we are talking about diabetes remission, not cure. So that is possible with the advancements in pharmacotherapy. So I'm going to skip this slide on medical nutrition therapy. Again, main problem is the maintenance of weight loss. So looking at pharmacotherapy, we now have a lot of agents that can alter the set point based on genetic and factors. So we can actually reset the set point. And with pharmacotherapy, patients are also able to adhere to lifestyle intervention. You tell an obese patient to go start a diet, it's not going to happen. They cannot exercise, they cannot walk. BMI is 40. So with pharmacotherapy, they have more energy, there is some weight loss happening, they're encouraged to do more exercise, and compliance with diet and physical activity will improve on pharmacotherapy. So that's an additional benefit. So these are the emerging agents. We are already using a couple of these agents in a big fashion, especially in North America. They are very popular weight loss agents now. There are other newer agents too. So I'm not going to the benefits. So we do have a better understanding of GLP-1 molecules as weight loss medications because they're very popular therapeutic options in diabetes. These are once weekly hormone injections being used very widely. I hardly prescribe insulin now. In fact, we are de-prescribing insulin because of the weight loss and glucose lowering effects of GLP-1 agents. And they have additional vascular protective effects on heart. This is independent of weight lowering and independent of glucose lowering. So you see direct effects on the heart. And this is the landscape of treatment of obesity drugs in the US. And we do see a specific drug called setmelanotide, which is for a genetic subvariant of obesity. That's an expensive modality. But in the general population, we are using liraglutide and semaglutide. It is a very popular option, and also naltrexone and bupropion, which is widely available here, I believe, bupropion. And then tirzepatide is a new kid on the block. So other agents in the pipeline, there are several agents being marketed. Obviously, almost 1 billion people in the planet are obese. So we do see a lot of money being pumped into obesity research these days. So I'm going to skip the comparative slides. So I'm going to specifically focus on GLP-1 agents. This is liraglutide or Saxenda, marketed as high-dose liraglutide, 3 milligram. Very potent once-daily medication for weight loss. We do see a good improvement in metabolic parameters, including fatty liver, histopathology resolution, and vascular benefits. But we do have better options now. Who wants to do a daily injection to lose weight? So we have a once-weekly GLP-1 agent, which is semaglutide, again, very popular drug in the diabetes world. The maximum dose is 1 milligram approved for diabetes management, but we are using a 2.4 milligram dose in another fancy name called Wegovy that's approved for weight loss in adults and also pediatric obesity. I think the age cutoff is 12. That's another emerging population crisis, pediatric obesity. So semaglutide once weekly, again, proven weight loss, and proportionately more patients are able to achieve that weight loss goals on semaglutide. And then there have been head-to-head trials comparing all these agents, and out of all the available GLP-1 agents now, semaglutide is more potent, and it's once weekly. Similar tolerability, of course, we often, and if we see patients having exaggerated GI side effects, often I send them for a GI evaluation. And this is not just the drug. Maybe they have hiatus hernia, maybe they have esophagitis. And sometimes a GI evaluation will certainly reassure, and then you can ask the patient to go back on the medication. Don't be discouraged with the GI side effects. Do slow titration. And once we do that, there is better GI tolerability to these medications. So again, all of these drugs have maximum efficacy when used in tandem with intensive behavioral therapy, and the adherence to intensive measures is more on treatment. So we do see combined effect. That's additive for sure. And this is the percentage change. And as I mentioned, proportionately more patients are able to lower the A1C, de-escalate treatment with other agents. I have a lot of patients on monotherapy with semaglutide, managing their diabetes and weight long-term. And we do have long-term safety data. And again, as additional benefit, we do see significant cardiovascular benefits from these agents, including liraglutide and semaglutide. There have been head-to-head trials across the board. We have dulaglutide and also another agent coming up soon. So these are the cardiovascular outcome trials, all showing tremendous cardiovascular risk lowering. This is in addition to other medications, including diabetes medications and statin. Again, another crisis is fatty liver and non-alcoholic fatty liver cirrhosis. So there is a significant histopathological resolution of pathology if initiated early, not when the patient is cirrhotic. So there are weight loss benefits and direct benefits of the drug on NASH. So practice points, liraglutide and semaglutide are currently the 2 GLP-1 agents approved, and higher dosing is needed for non-diabetic weight loss management. So of course there is a higher incidence of GI side effect, which can be tackled easily with appropriate counseling. Now coming to the second popular agent, this is a therapeutic combination of naltrexone and bupropion. Again, works mainly in the central nervous system. I'm not going to the mechanism of action. Slow titration, again, start with 1 tablet, and then final dosing will be over 4 to 6 weeks. You can do a target dose of 2 tablets twice a day. Very efficient for weight loss, and especially when the patient also has mood disorder, perimenopausal women, postmenopausal women, this is a good option. And also for patients with eating disorder, binge eating, this is indeed a good option as a weight loss option. And if we don't have the combination, we are also using these medications separately. So you prescribe bupropion separately and naltrexone, so that way the high cost can be mitigated. So that's one option, and again, significant amount of sustained weight loss. So this is trial data, but in real world, we do see more weight loss and good appetite suppression as well. One thing we are also trying to understand is that whether you do GLP-1 treatment for 1 or 2 years, patient cannot afford, or patient has achieved a lot of weight loss, and how do we maintain that? Maybe use one of these agents, maybe 1 or 2 tablets of bupropion naltrexone combination. So this is something we are trying to understand whether that will work long term. A lot of our patients are on SSRIs and other mood pills anyway, so this might be a combination. A sequential treatment is something that we are interested and we are now looking at. And bupropion definitely has a propensity to cause seizures, so we have to look for drug interactions, and also contraindicated when the patient is on opioids. So again, generally good tolerability from real world experience. Mostly patients are able to tolerate these drugs, and also with the weight loss, we can lower the burden of polypharmacy. So that is trial data, again, particularly important in patients with binge eating and other, as I mentioned earlier, there are some subtypes of obesity patients who might particularly benefit from these sort of selective interventions. Another new drug is a once-weekly human amylin analog. This has now been studied in combination with semaglutide, again, once-weekly intervention, so multimodal approach using 2 therapeutic agents once a week. Again, really good. And interestingly, even though the GLP-1 dose is higher, GI tolerability is pretty much comparable, so that's encouraging. We do expect that, when the dose is higher, maybe there's more GI side effect, but that's not the case. The good GI tolerability or stable, depending on how well you titrate it. And then tirzepatide is the latest drug. I think we're going to start using this drug from next year. Double weight loss and double A1C lowering, and we are seeing graphs that are touching 0 in terms of reversibility. This is a very potent anti-diabetic drug to be available soon, marketed by Eli Lilly. So it's a dual incretin agent, GLP-1 GIP agonist, and other triple agonists are also being studied. And this is the trial data from tirzepatide, the dual agent. Trial data is now published. So we do see, in comparison to semaglutide, we are seeing double weight loss, as I mentioned. And this is a meta-analysis comparing the efficacy of various weight loss drugs. And the efficacy-wise, they are all good, but we are not using much of phentermine topiramate because of CNS side effects. So GLP-1 agonists and naltrexone bupropion are the most popular and evidence-based and safe therapeutic options. So I think that's it, and I'm happy to take questions. Yes. Oh. Yeah, SGLT2 agents are being studied, but again, the potency is not as great as the GLP-1, because there you see, so that's why, yeah. But that's mostly in diabetes, sir, because in the glycosuric action is also because you're losing calories through that altered threshold point. So we don't know if we will see the same amount of weight loss in non-diabetic, because in diabetes, the glycosuric threshold is different, and the SGLT inhibitor is actually altering that threshold. So we may not see that amount of weight loss in a non-diabetic individual. We don't know. I mean, that's probably, I mean, it is definitely an adjunct treatment for sure, like even in individuals with pre-diabetes, like you said, metformin and SGLT2. Yeah.
I will introduce myself. I am Dr. Basi, completing nearly 50 years as a medical teacher and a medical practitioner, fully accepting the fact that genetic factors contribute to diabetes. I would like to mention a few points. One, when I was a student in the school, in my village, there is a lot of contact with all the public there, walking every day. I have not seen a single person with obesity except one of my classmates' mother. One of my classmates' mother at the school, upper primary school. And I did not know why that person alone was diabetic. I came to know why he was obese. Why he was obese when only I became a medical student. That's the only house where there was a servant. All other houses in my village, there was no servant. And everybody, for purchasing every article, used to walk at least 4 to 5 kilometers every day. Because if you want to purchase fish for us, my mother used to walk 2 kilometers forward and 2 kilometers back. And for everything, less than 3 to 4 kilometers, nobody used to go by bus. Because bus you got to wait for 2 hours, 3 hours at a place. And next point I will say that if you are taking, say, 1 cup of tea and a vada extra than what is required per day, it will approximately cost 20 grams of weight gain. Extra calorie other than what is required for the activities. And 20 grams per day calculated into 1 month is 600 grams. Into 1 year is 7.2 kilometers. And for 5 years, it will be 35 kilograms. In other words, if you are taking 1 cup of tea plus 1 vada extra than what is required as additional calorie, in 5 years, you can gain a weight of 35 kilos. That means weight is not obtained over a few months. And next third comment is, I have one patient who was an assistant executive engineer in KSCB, coming from a well-off family, came to me for hypertension. He was obese. Ideal weight about 20 kilograms. 2-3 times I insisted that you must change your weight, reduce your weight by calorie and exercise. And then he refused to come to me. And after 2 years, when I was going for a morning walk, he was coming from the opposite side. Look, I could recognize a person. He has lost 13 kilograms. Then I asked, sir, I told you many times to reduce weight, but you did not reduce even a gram of weight. What has happened? Doctor, I did not come to you. I had a myocardial infarction. And then I went to the cardiologist. Cardiologist said, unless you reduce weight, your life is lost. I think you are Malayali. I think he said, Doctor, Jeevane Pedillata Arakil Unda Doctor. So I was forced to date. I said, did you take any drug? No. Weight loss. I had never prescribed a drug for obesity. So many drugs have come in the past. Many of them have been banned subsequently. And many of these drugs, if you forget about the academic alone and evidence-based alone, and if you come to ground reality, how many of the Keralites with obesity, how many of the Indians with obesity will be able to take semaglutide and liraglutide? And if they are consuming that, I am sure that other members will be suffering from famine. And last comment is, in 2018, BMJ, there was an article saying that about 12% of the Indian population is converted from average group into BPL by medical treatment. And last one more comment, last comment. Just 1 minute, 1 second below. Editor of NEJM for more than a decade, after retirement from NEJM, wrote in the journal that many of the controlled studies are so much manipulated by the drug industry, it is so difficult to believe the result. Maybe maximum 50%. This article which has come. The editor has written, and so many other journals also it has written. Most of the randomized studies, maximum truth is 50%. Including Canada, US, India, everywhere, drug company has got tremendous influence on all the journals, including the so-called copy the receptor. Is a tremendous amount of money is given to the journals.
So we have a
these
session
are some of the
by
facts
Dr. Vinod.
Yeah, sir, regarding the points you mentioned, they are well taken. But definitely we are seeing
I am not saying that
clear weight loss with all these medications. We are
weight loss,
in
liraglutide, I have prescribed
Yes.
because of the cost. It is
and
unknown to produce.
your point is
It
also
is
well taken that
cardioprotective
diet
also,
and
very good
exercise
for
is the
diabetes.
primary thing, and madam has mentioned that we all first go with diet and exercise only when we don't
I am
find
not against that.
Yeah.
I was
The
saying
second
that
line,
you come to the
Yes.
round reality.
It is only
these
second line.
factors
All of
also
these
must
are
be taken
second
into
line
Sir,
treatments.
I think
Basi sir, I think you made your point.
right.
I
Let
think
us discuss it over coffee or tea.
I think we no more questions are
Throughout the
allowed.
morning I did not talk. Only
Okay.
Due apologies to you, sir. No more questions. We are already running out of time. Over to.
So when the Trivandrum Medical College Alumni Association searched for a name to name its medical academy for knowledge transfer, we reached a decision very early. It can be and it should be Professor V.C. Matthew Roy. So we have the V.C. Matthew Roy Medical Academy, which conducted all the 15 webinars during our COVID time.
Yes.
Thank you.
Thank you, Nisha madam, for that excellent presentation.
We request the chairpersons to hand over a token of appreciation to the speaker, Dr. Nisha Nijal Haroon. We request Dr. Dayananda Babu to present a token of appreciation to the chairpersons, Dr. Aruna R. and Dr. Abhilash Nair.
The last session of the day is the Professor M.A. Akbar session. The chairs are the last but one. The chairs of this event are Dr. K.P. Haridas and Dr. Ajay Kumar. I request the chairs to take the stage. Thank you.
So we named this session after Professor M.A. Akbar, who is dear to all of us. So
Do you expect me to talk something about Dr. Akbar? Yeah. From my mind, actually the best person for this would have been Dr. Vijayan. He's his classmate, but he has been one of my close friends and also colleague in the Calicut Medical College. I joined in 1962, he joined in 1963. And in the surgical department as professors, he was just senior to me actually in PSC. So he became senior. He's a fantastic human being, superhuman, amazing personality, very jovial, friendly with the students. He has contributed several things in the sense, he has written a book on surgery, and he has been a good teacher, and very touchy, very lovable character. And on top of that, I always thought he used to think above religion. That is what I found in him. And fantastic person, that's all what I have to say about him. Dr. Vijayan, would you like to say something? He has been a close friend. Do we have this? Okay, fine. Let us now start off with Dr. Vinod, actually. I wouldn't say Mr. Vinod, FRCS, MS FRCS, and it's a privilege to chair this session. And about him, actually, his uncle, Dr. Madhumohan, I don't know whether he's here, he's a very close friend of mine, and your father was my teacher, and MEP, your uncle, is, MEP is your uncle? As well, yes, he is my classmate, and so many connections. Surgeons are two types, in fact. There are some surgeons are born, some are trained. He's a born surgeon. That he has shown, and he has become one of the top surgeons in England. He is a clinical professor in the University of UHL, that is
Warwick.
University College, Coventry and Warwickshire. Yes, Warwickshire. I'm not reading. In fact, that will take more time. So I leave him free, actually. In fact, I asked Dr. Vasudevan as well as Dr. Panikar, why not you give an opportunity for me to talk about obesity and metabolic surgery? I said, next time. First time, for Dr. Vinod, next time for me. So I'll be talking about my obesity treatment, surgical treatment. I believe that's the only sustainable way to lose, a sustainable thing to lose weight. Sustainable weight loss is attained only by surgery. Not losing 10 kilos or 15 kilos is not going to help at all, absolutely not. And you know the status in Kerala, 20% of the population, or 25 to almost 25% of the population, 1 in 4, 1 in 5 definitely is overweight or obese. We have 1.5 billion people obese in the world, either overweight or obese. We can divide half-half. Out of the 7.5 billion, we have to be very careful. This has to be taken as a separate specialty, as a single specialty, like cardiology and cardiac surgery. And we are ignoring, physicians and surgeons, everybody is ignoring. We are not aware of what is happening in Kerala. And I see quite a lot of them. In fact, and also about diabetes. The Indian average diabetes is 8%. In Kerala, it is 20%, 25%, 20 to 25%. Same case with obesity. So there is something to go with obesity. Diabetes, that is obesity. Obesity is the main cause of diabetes in our country, any country for that matter. With these few words, I'll stop and hand over to Dr.
Yeah, over to Dr. Vinod Menon. No, I'll be talking later.
Okay. Thank you.
Please carry on.
Yeah, thank you. Good afternoon, respected chairpersons. Professor Haridas is my teacher, and Ajay Kumar, Professor Ajay Kumar is my good friend and colleague. I'm not naming any of my teachers because I'll miss somebody, but I cannot just not mention Professor Ramushan Nair, who's taught me the art and science of surgery, and amongst them there are several others, ladies and gentlemen. It's a proud privilege to be here today. This institution is special to me. I was born here, I qualified as a doctor, and I trained as a surgeon here. My father, late Professor M.R.S. Menon, worked his entire working life here. He took his last breath here. So this place is really special to me. And my mother and my wife were my fans and my critics. They're both here today. It's the first time in my life they're both here at the same time. So it's a special day for me. And also this session is dedicated to Professor Akbar, who was my teacher. And I learned a lot from him. And there's one thing I especially learned from him is to interpret plain X-rays. Those were the days when we did not have free access to CT scans, but he took us there's a weekly evening radiology class. So my humble respects to Akbar sir too. Nisha did a fantastic talk on the medical management of obesity. It's a complex problem. And I think this is not the Football League of Nations, it's a league of overweight nations. And no particular country can take pride apart from maybe Korea and Japan. Obesity is associated with multiple comorbidities. I'm not going to list them all. There's plenty out there. And what's more important is we've just gone through the COVID pandemic, and there's a well-established relationship between obesity, diabetes, COVID-19, and mortality. And if you look at cancers, and Nisha touched upon this, and I'll show a slide a bit later on. So this affects every single system. and also obesity reduces the life expectancy. So it's a huge, huge problem. We talked about genetic dyes. In this particular paper in PLOS Genetics a couple of years back, the genetic dyes is really supportive of thinner patients because they have very few genetic variants that make them becoming overweight. And people with obesity have an increased number of genetic variants. So there's something about how we are born, where we are born, and our genetics. This particular picture, which appeared in the Lancet about 20 years ago, I believe from a South Asian wedding. And you can look at both the gentlemen, equal body mass index. But look at the gentleman, the South Asian gentleman, his body fat is 21%. So it's not just the body mass index, there are far more subtle features. The gastrointestinal tract has always been mentioned as a mediator. There are lots of signals. If you look through the stomach, the pancreas, the colon, the 3 bits of the small bowel, they produce a lot of hormones and enzymes which affect the glucose and energy homeostasis, manifesting as obesity and increased body mass index. Coming to my ask of me is to talk about bariatric surgery and the evolution of bariatric surgery. Dr. Edward Mason is considered to be the father of bariatric surgery because he described the Roux-en-Y gastric bypass in 1966. And this operation is still standing 56 years on. He described that operation and he noticed that in patients who had gastrectomy for cancer or for peptic ulcer disease, it cured it didn't cure the cancer, it got rid of the cancer, cured the ulcer, peptic ulcer, but most patients lost weight. So it made him think, if you divert the alimentary tract and exclude a certain section of the small bowel, patients will lose weight. This gentleman, he died at the age of 100 during the COVID pandemic. If you look at appendicitis, I mean, the days when Akbar sir, Vijayan sir, and Haridas sir taught me to do appendicectomy, it was an open appendicectomy. And then it became laparoscopic, and now some people do it robotic. But the essence, the appendicectomy has not shifted. Similarly, if you have gallbladder disease, you have a gallbladder removal. Open cholecystectomy, laparoscopic cholecystectomy, robotic cholecystectomy. The essential operation has not shifted. But if you look at bariatric surgery, there's about 25 different operations listed, which means there are different ways in which one could approach the gastrointestinal tract and do all these kind of mediator regulation, which results in weight loss. So there's no one size that fits all. The Swedish obesity subjects trial in 2004 reported on the 10-year results of bariatric surgery. And they found that surgery, which is gastric bypass or sleeve gastrectomy, had much better results in terms of weight loss as compared to controls. The 20-year outcome, particularly looking at the long-term cardiovascular events, found that the weight loss was maintained or rather sustained at 20 years. So it lasts a long time. Selection of surgery, I think Dr. Titus was asking, what's the selection criteria for surgery? And I touched upon the body mass index and how it's not the best descriptor. But for purpose of understanding, the body mass index of more than 40 or more than 35 with 3 particular comorbidities, type 2 diabetes, hypertension, and obstructive sleep apnea. And now that there's a higher incidence, higher interest in diabetes resolution, that threshold is lowered by 2.5 in people like us of Asian origin. And this is the National Institute of Clinical Excellence guidance that we use in the United Kingdom. And I suspect, Nisha, it's not hugely different from what you practice in Canada and the US. And you complete a structured assessment and anesthetic risk and all that. The simplest technique is endoscopic insertion of a gastric balloon. Does not require a general anesthetic, done in the endoscopy suite. You place a balloon into the stomach, there you go, into the stomach and fill it with about 500 ml of saline with a bit of methylene blue. So it makes you have a full feeling as if you've gone to a big Pizza Hut or gone to McDonald's and had a full meal. But this balloon has got to be removed at 12 months and patients can have rebound weight gain. The patients lose 15 to 20 kilograms within that period, and we hope they develop a new eating pattern. Gastric banding was very popular about 10 or 15 years ago. Simple technique, laparoscopic technique, possibly overnight stay in hospital, but it had a few complications, and the weight loss was reasonably modest. So it's given way to, or kind of faded away a bit, and taken over by gastric bypass, which used to be very popular 10 years ago, much higher weight loss, significant and fairly quick resolution of diabetes, but because of a 2 anastomosis, you bypass about 2 of the 5 meters of the small bowel. So food does not get digested or absorbed during the 40% to 50% of the small bowel. And patients lost weight and they ended up being malnourished as well. The single most common operation worldwide currently is this technique called a sleeve gastrectomy, where you remove about 80% of the stomach and convert the rest of the stomach to a narrow tube with a little pouch at the bottom. 2-day hospital stay, 98% laparoscopic surgery, and you get 60 to 70% excess weight loss in good hands. I'll talk about weight regain in a minute. So this is the single most common operation worldwide currently. Mini gastric bypass, I know Professor Ajay Kumar has done a huge experience in that. It's a modification of the Roux-en-Y gastric bypass where you have one anastomosis instead of two. So you create a small gastric pouch and exclude the rest of the stomach and connect the small bowel about 200 centimeters distal to the duodenojejunal flexure. It's got two anastomoses instead of one, reduces the complication rate, and has, Ajay's got lots of experience and he's got excellent outcome in his hands. There are some experimental techniques like the endobarrier, which is a sleeve which is inserted endoscopically, and it excludes the duodenum and the first 30 to 40 centimeters of the small bowel. Exactly the same principle as a bypass, but it's put in endoscopically. This technique has unfortunately faded away. There's been some complications. Just for completion's sake, there's a technique called gastric plication, where you plicate the stomach. Stomach becomes exactly similar to a sleeve gastrectomy, but you don't remove it. You stitch the stomach, like inverting the stomach. The danger is these patients could develop a gastric cancer and go unrecognized. So it's not used that much. There are some centers that use it. In summary, there are several mechanisms that mediate the beneficial effects of surgery. And I'm not going to go through all that. The intestine adapts, there's fat metabolism, bile acid metabolism, duodenal exclusion, the vagal effect. It's not sure what each individual component contributes to it, but all in all, it works and results in significant weight loss. This particular slide is relevant to each and every one of you in the audience. I know even to, Najib talked fantastically well about, cardiovascular risk factors. Ali Aminian from the Cleveland Clinic published this in JAMA. If you look at all-cause mortality, that's controls, that's bariatric and metabolic surgery. There's a significant reduction. The same thing applies for coronary artery disease, for heart failure. And if you go one bit further, even for cerebrovascular disease, nephropathy, we had a fantastic lecture now about the effects on renal disease and obesity. If you have metabolic bariatric surgery, your risk reduces significantly. And similarly, it applies to atrial fibrillation. So this is great outcome following bariatric surgery across all aspects of the body. Particular thing about bariatric surgery and cancer risk, this was published by Phil Shore in the Annals of Surgery. They looked at about 90,000 participants, and there were 2,000 index cancers, but statistically significant reduction in the overall incidence of cancers, and particularly for endometrial cancer, postmenopausal cancer, and colon cancer. So there's a link between overweight, obesity, and cancer, and how bariatric surgery would improve the outcome. What about weight regain? All operations are good and ideally should be successful, but 20% will fail to maintain that meaningful weight loss, and patients ought to be educated. Did the operation fail the patient, or did the patient fail the operation? As clinicians, we would like to believe that it's the patients who failed the operation, but not necessarily. How can you reduce non-compliance from patients? You select your patients carefully, educate them, evaluate them, perform the right operation, and give good long-term follow-up. That's the way to maintain weight loss. However, we know as gastrointestinal surgeons, even if you remove a certain section of the stomach expands, the stomach dilates, the small bowel dilates. There are societal and cultural factors which make us go back to our old eating habits. So there is a certain bit of both. And we all use medications for our patients, prescribed medications, antipsychotics, antidepressants, steroids, antiepileptics, antihistamines. All these contribute to weight regain. Believe it or not, the body weight is aggressively defended like a thermostat controls body temperature. So whatever we do to reduce the body weight, there's a body thermostat which tries to regulate it back to where it originally was. I fully support what Nisha said in her talk, the utility of weight loss medications. Here's a result of a big multi-center trial looking at the role of weight loss medications after bariatric surgery, and there's a statistically significant improvement. So surgery should be complemented with medical treatment, and it's a combination treatment that produces the best outcome. Some of these patients who put on this extra weight would need to have revisional bariatric surgery. It convert a band to a sleeve, a band to a bypass, or a sleeve to a bypass. So revisional surgery is also becoming increasingly common. What is metabolic surgery? We talked about bariatric surgery is for weight loss. What about using the same technique to control diabetes? I'm not meaning curing diabetes, to put diabetes into remission. We all know that one of the most significant advances in medicine in the 20th century was 1921, Banting and Best about insulin, which revolutionized the treatment of diabetes. Certainly treated diabetes, but did not cure diabetes, did not put it into remission. But bariatric surgery, when used for diabetes, called metabolic surgery, puts diabetes into remission. And if you target these patients early on, it can prevent the micro and the macrovascular complications of diabetes. The Stampede trial, again from the United States in 2017, looked at a group of patients with diabetes with medical treatment and surgery. And as the results show, this was published in the New England Journal of Medicine, surgery had a statistically significant advantage in controlling the disease. And there were 11, altogether there were 11 randomized control trials looking at the same question, medications, insulin, all the diabetic medications, and lifestyle versus surgery. It definitely favors surgery. How the surgery works, how the same surgery, metabolic surgery works in resolving diabetes, putting diabetes into remission, is a combination of the surgical effects, the mediators and other mechanisms, and finally its impact on glucose homeostasis. Again, similar to weight regain, a percentage of patients whose diabetes goes into remission, they will relapse. At 2 years, 75% of patients have good resolution. If they go off their insulin, they go off their metformin. But if you follow it up for 10, 12 years, a good percentage of diabetic patients recur, they relapse. That is where I think the role of the medications that Nisha so eloquently pointed out, for example, liraglutide, we're very proud of this study which came from the United Kingdom called the Gravitas trial, which looked at the impact of liraglutide in patients with persistent or recurrent type 2 diabetes after metabolic surgery. So the point I'm trying to prove is not just surgery, it's not just medication, it's in combination. The right combination serves patients best. Finally, to finish off, I think we need to look at the outcomes. There is a myth amongst the general population that bariatric surgery, metabolic surgery is extremely unsafe. I think that's got to be dispelled. The United Kingdom National Bariatric Surgery Registry has got 88,000 patients on it, and the mortality rate on those 88,500 patients is 0.004%. Or in other words, bariatric surgery is safer than laparoscopic cholecystectomy, safer than primary coronary artery bypass grafting, safer than a hysterectomy, safer than a single knee or hip joint replacement. And this is the data. And on this screenshot, you see my data from over 1,000 patients. I would not tempt fate, and I would not go into it, but it shows everything, the types of procedures you do, the weight loss, and the length of stay, and everything. It's got excellent outcomes. How do we achieve that? You have this proper infrastructure. You do not compromise on patient safety. And I think that's a key thing. Never deviate from what you do normally. Develop your team, respect your team, nourish your team, and the team works for you. The team, ultimately, it's the patient who benefits, and nurture your team. Look at patient feedback very positively. I mean, this is a complimentary one. Occasionally, you get complaints, and use that to improve your services and to make yourself a better clinician and a better surgeon. We occasionally get complications, and I do as well. And I think if a surgeon ever stands up and says he or she has never had a complication, it can only mean one of two things. Either it's not done enough, or it's not speaking the truth. So we get our complications, and this is one of my own patients who had a sleeve gastrectomy leak, and I leaned on my gastroenterology colleague who worked with me, and we used lots of endoscopic and radiology measures. You can see a stent here, and got the patient through the difficult period. There's a media influence about perception of obesity, and we as responsible clinicians should do our best to dispel that myth. There's a prejudice about, you go into a crowd and you see somebody who is obese, there is always some kind of comments. It'll take a generation for that to move. But we as clinicians should fight the prejudice about obesity, the prejudice about bariatric surgery, and also sometimes about the bariatric surgeon. Technology and innovation, one's got to embrace it very safely. And the robot came 5 or 6 years back, And we use the robot for selectively, but this is me with my mentor, a very experienced surgeon from Portugal. So you've got to introduce new technology very safely and never assume that you are the best at what you do. I came here yesterday and the first talk I heard was from a psychiatric colleague who talked about work-life balance. And as surgeons or as clinicians, we have a finite life span as a working clinician. It could be 20 years, it could be 25 years. But never forget your wife, your mother, your children. Because at the age, but comes the stage when you've got to lay down your tools. And you should never sit back and think. I'm not for a moment saying I've done it best, but you've got to think about it as you progress in your career. So to close off, the future of bariatric and metabolic surgery, these are my thoughts. There's going to be an exponential increase in numbers. The problem is increasing. It's a real pandemic. And we should have a united front against prejudice for both media and social campaigns. If you're a complete surgeon, you should have the whole armamentarium, should be able to offer almost every operation. The safety profile is excellent. And there is no other operation, be it coronary artery bypass grafting, be it brain surgery, no other surgery will attack or target 3 or 4 comorbidities in one stroke. So this is the beauty of this surgery. Patients got to be fully involved in decision-making, teaching, training, research, and innovation. Standardize the procedure, enrich your teams, and do everybody to do the same thing. And once again, a focus on outcomes reporting, because there's to dispel the myth of high complication rate. And I would leave you with those final thoughts. Thank you.
Thank you, Dr. Vinod, for the excellent talk. I am really proud to chair the session, and 1 minute at the introduction time I could not talk. So I'm really humbled and honored to chair this session. And Akbar sir was like a father figure for me. He's the one who gave knife to me in my surgical career. It was on a final year. I was a final year student. It was a strike day. PGs and house surgeons were not there. We were only there to help sir. So from that day onwards, I was so close to him. And until his last days, I used to visit him. And it was, even though it was an accidental coincidence, though I'm a bariatric surgeon, it was Akbar sir's session. That makes me very happy. Thank you very much, organizers, Panikar sir and Vasu sir. And one question for you, for the benefit of the surgeons in India. Among the various procedures, which one you find suitable for South Indians? We have 3 popular procedures in Kerala. Yeah. Sleeve, MGB, RYGB.
Yeah. Okay. It's a good question, Ajay. And I think I would even take away the South Indian aspect of that question. Of those 3 procedures, no operation is simple. Every operation's got its small tips and tricks. And I think there's no doubt that of the 3, the Roux-en-Y gastric bypass is probably the most complex, because it's got it's got potential for more complications, more malnutrition, and also the technique of 2 anastomosis. The sleeve gastrectomy people perceive as a more simple procedure, but you have 6 or 7 long firings of the stapler. And if you're not very good at firing them, or if the patient fails the operation, then the consequences can be disastrous. The single anastomosis gastric bypass, and I know that you're a real master at that, is a great operation, because it combines the benefit of both procedures. It's got a single anastomosis. You're not doing any, you're creating a very safe pouch of stomach. And my only concern with the malnutrition, with the malabsorptive operations, is the follow-up, which in the Western world is much more well-defined, and most patients get it consistently. And therefore, the sleeve, in an Indian context, achieves a similar degree of weight loss, but there is less stress on the other group, and there's less chance for the operation to fail from a nutritional perspective. Those are my thoughts. Yeah.
Can I comment on those, actually? There are 2 procedures only I do. That is, the common thing is mini gastric bypass for the last 10 years. This started by Rutledge in 97, but taken up later on. I've been doing it for 10 years. Diabetic remission, obesity with diabetes, mini gastric bypass. Obesity surgery, when you say bariatric surgery, it is weight loss surgery. If you have to cure diabetes, you have to do a bypass of the intestine. because the nutrient chyme reaches the lower ileum faster, so that GLP will be stimulated, and thereby there is stimulation of insulin. So I have almost 120 patients with mini gastric bypass, and 80% of them are cured of diabetes. They have not come back. That is my favorite operation, and that is being commonly done in India mostly. And this is coming down. Sleeve gastrectomy is on the whole coming down, isn't it?
Yes, sir. Even though I am doing MGB, sleeve is the most common procedure in India. The problem with sleeve is weight regain is more, complications are more.
Absolutely, and also ruined by gastric bypass. 10 years you can wait because
MGB, as Vinod said, you need strict follow-up. Otherwise, patient will land up in malnutrition. So we have to have a selection of procedures, not a single procedure. Yeah, that's the most important thing.
And one of the surgeons in Kerala, Dr. Ismail, Mohammed Ismail, he has more than 1,000 odd cases of MGB. Do you know him?
I know.
Yeah, okay. Yeah, that's right. So
any questions from the floor?
Yeah, I particularly didn't mention it because there are two operations, the biliopancreatic diversion and the duodenal switch. They are very, very, they're performed very uncommonly these days because it's a technical difficulty and also the follow-up with the nutrition perspective. And because the sleeve or the mini gastric bypass provides almost similar excess weight loss and comorbidity resolution.
in fact, there is one more surgery called SADI, single anastomosis duodenal bypass, SADI. After sleep, you connect it to the intestine to the duodenum, SADI, single anastomosis duodenal.
Yeah. Yes. No, surgery works. Quite often, that's the role of the medications that Nisha presented. You know, the GLP analogs. So you got to keep them. The diabetic patients have got to have yearly follow-up for their neurological evaluation, the nephrology, and the peripheral neuropathy. And if there is any sign of it coming back, you should use the medications. Is that right, Nisha? Yeah.
What is your BMI for referring to surgeon? When do you refer your patient? Oh, it's different. No. What is your criteria?
It's fairly similar. It's a 40 and 35. Yeah. No. I do a fair bit of robotics, but 95% of my bariatric is laparoscopic. I just mentioned that, so there are new technologies, and you got to innovate safely. Yeah.
Okay, thank you very much.
Excellent. Balloon's really going to take off, Najib. The two reasons. One is the indication for balloon. It's from BMI, at least in the UK, from 27 to 35. Those patients will not fit the criteria for any formal surgery. And also the super obese patients, somebody's got a BMI of 70. And if they have a balloon for 12 months, they will drop their BMI by 12 to 15 points and make them a much better surgical candidate.
And in fact, we are taking those with BMI 32, even 31, with diabetes for mini gastric bypass.
No, I think the balloon is, because, and also I've done 3 or 4 patients put balloons in before they went on to have live-related kidney transplants. So they have a certain threshold for the recipient to have that. So.
Okay.
Thank you. Thank you, sir.
We request the chairpersons to present a certificate of appreciation to the speaker, Dr. Vinod Menon. We request Dr. K.N. Vijayan and Dr. we request Professor K.N. Vijay and Professor Shivashankaran to present. We,
Story of my scalpel. I don't know whether you have heard of it.
we request Professor K.N. Vijayan and Professor Shivasharangaran to present the token of our appreciation to the chairpersons, Dr. K.P. Haridas and Dr. Ajay Kumar.
I'll request Professor M.K.C. Nair sir to present the Lifetime Achievement Award to Professor Haridas.
Namaskaram. Wonderful to see you. So nice of
The next session is the Professor Krishnan Nair oration. To confer the Professor Krishnan Nair Oration Award, we call upon the chairpersons, Professor C.S. Madhu and Professor Chandra Mohan. Professor Krishnan Nair Oration Award has been conferred to Dr. Cherian Verghese. We invite the former Vice Chancellor, Dr. M.K.C. Nair, to confer the award. And the Vice Chancellor, Dr. Mohanan Kundamal.
Dear colleagues, first of all, I would like to thank the organizing committee for giving me opportunity to chair this session, which is in memoriam to my mentor and teacher, Professor Krishnan Nair sir. He has been my undergraduate and postgraduate teacher, and I had the opportunity to be with him in the Department of Radiotherapy, bar RCC, from 84 to 1991. And some of you may not know, the Department of Radiotherapy, actually the cancer department of Trivandrum Medical College, was situated in the ward number 11, 12, 13 of a Medical College Hospital, in a very pathetic condition, where there were a lot of really advanced cancer patients, and nobody used to care. Especially, we students used to go to these wards during exam time, because very often the cases were selected from those wards. So Krishnan Nair sir, he had the fortune to be deputed to Christie Hospital, Manchester, because of an agreement between Trivandrum Medical College and Christie Hospital. It was all because of Professor Thangavelu, the principal at that time. So he came back after the FRCR qualification and was posted in Kottayam Medical College and then came back to Trivandrum. And from then onwards, the department took a different shape, and it was one of the most appreciated and recognized training centers for clinical oncology. We all know how difficult it is to organize something in a government setup. As a professor in the government medical college, he could manage to organize that department to a regional cancer center. And I remember the day when the foundation stone was laid by our beloved Chief Minister Karnagaran sir at that time. From then onwards, that institution was brought up by him. He had taken pains to train all his students, subordinates, and we all have to learn from him the methods. He used to invite faculty from UK, USA, etc. on various schemes, and he allowed them to mingle with the faculty, and that is how the technology transfer was executed. Similarly, British Council sponsored so many teaching programs he arranged. And he was one of the persons to get the Padma Shri award, and also he was awarded FRCP London. So Krishna Nair sir, I would rate him as the best doctor Kerala has produced because of one reason. See, we all know when I joined this college, there was a miniature of a city in the principal's office. And with the able guidance of P.K.R. Vair sir and then Sambashivan sir, the institute was built and supervised by the engineering college faculty, and the big building came. And on a fine morning, Valiathan sir was given the honors of being the director of that institute. On the other hand, Krishna Nair sir built it from the scratches, and he organized it into one of the foremost cancer centers in the country. So he has a lot of publications. He brought up cancer research in Regional Cancer Center, the Pediatric Oncology for the first time in India, Community Oncology for the first time in India. He started the medical oncology and appointed Dr. V.P. Gangadharan. And above all, the greatest cancer surgeon probably India has produced, Dr. Thomas Cherian. He was appointed and he was sent to UK for training, and that's how the RCC came to what it is today. So I also have the great happiness in seeing my undergraduate junior, Cherian Varghese, to present this talk in memoriam to Professor Krishna Nair sir. Chandramohan, you want? Okay.
Thank you, Dr. Madhu and chairpersons. Good evening, my teachers, ladies and gentlemen. I think Dr. Madhu has given you a reasonably good idea of what I was trying to say. And I will dedicate this to Dr. M. Krishna Nair, sir, and we'll call it Cancer Control Yesterday, Today, and Tomorrow. So, as we have heard already, even in the previous session, cancer control needs a wide range of options. And just to tell you, if you look at the life history of Dr. M. Krishna Nair, sir, as has been briefly presented, it has been so significant that he could actually take on any topic, not just cancer. Even if it is obesity, I'm sure Dr. Krishna Nair, sir, would have spoken. But I think this is all what we need to remember about this person. He has set up the first modern, affordable cancer care center in Kerala's public sector. That is no joke. I've been across the world in WHO. There are very few cancer centers of this status across the world, actually. From these days, we always talk about our professors with the mnemonics of Dr. Joy Phillips, sir. So if I look at the mnemonics of M. Krishnanath, sir, he was always very kind. He's very resourceful. He is an extremely intelligent person who can actually understand quite complex theory very fast. He was very social. If you go to Trivandrum Club any day, you will see how social he is. He was always very happy, even in the midst of a lot of difficulties. If you go through RCC, you will hear his laughter and his smile. He is very nimble, he is adaptable, and he is nurturing, and that is Dr. M. Krishnanath, sir. So I just wanted to sort of say that how great he was as a human being. So I work at WHO, and we have just produced the WHO report on cancer, which is the latest report. And if you look at that, there is nothing new there. It still says formulate plans, fund priority cancer interventions, build capacity, develop a workforce, partner with communities, and strengthen information systems. This is what Krishnanath sir has done from 1980s. As Dr. Madhu has clearly said, he has worked ahead of his time. That is the most important thing. Krishnanath sir could see into the future almost. You see the Cancer Care for Life, and that is Dr. Ms. K.S. Chitra actually sitting there as a young girl there. Cancer Care for Life was such a fantastic insurance that he thought of. If you pay 100 rupees, you can get cancer treatment up to 50,000 rupees in RCC, and 50,000 rupees was a big amount at that time. With most of the epithelial cancers, that was quite feasible. Even now, how good is our Atmanirbhar Bharat with 5 lakhs rupees, we don't know. Because the markets have changed and the prescriptions have changed. But he had the vision to sort of bring in a cancer life insurance at that time, which is still working actually. The people who have contributed 100 rupees are still getting benefits out of that. Another important aspect is the way he actually sort of thought about all the various specialties. Who would think of appointing a dentist in a cancer center? Nobody. Who would think of appointing a palliative care program in a big hospital? Nobody. I go to various cancer hospitals, they are still scared of talking about palliative care. So people are still caught up in very narrow clinical sense of things, whereas Krishnanath sir could actually see it much broader. In fact, I wrote with sir this paper called Regional Cancer Center Trivandrum, a green park for epidemiological studies. That was the time when Mr. Vijayaraghavan was setting up the techno parks, and we were saying this is a park for epidemiological studies. I recently developed this, how to develop a cancer center with the WHO and the International Atomic Energy Agency, which was just published last year. And the main elements of the thing when I wrote this book was from what Krishnanath sir has done. So if you look back what some of the key elements in the cancer control in the past, you know that Kerala has one of the highest background radiation in Karnataka. There are only 2 or 3 places in the whole world. One is in Brazil, one is in Kerala, and one other place where people live in naturally high background radiation. So Dr. Krishnanath sir at that time, with the help of Japanese colleagues and with the Baba Atomic Research Center, carried out a study of 400,000 people with full data, including background radiation, and have shown that very low levels of background radiation have not shown any increase in cancer, which still stands so good actually if you look at global radiological protection. You get into neck node dissection. I think oral cancer and head and neck cancers were so high, patients with neck nodes up to 1 centimeter can receive radical radiotherapeutic management. Was a significant paper which actually got the Indian Surgical Oncology Award at that time. In 1992, Krishnanath sir could say that what is the survival for stage 1 breast cancer in Kerala in RCC, it is 90%, or for oral cancer. Today, how many cancer hospitals in this state can say that what is our survival rate? Cancer hospitals talk about big machines, big people, big degrees. I have not seen any cancer hospital advertising, we are a great cancer hospital in Kerala, please come and get treated, your breast cancer survival will be 95%. No. They say we have the latest machine, we have the latest person, we have somebody who has come from this country and that country. So I think this actually shows that outcome-oriented interventions are so important in cancer. That is the single most important thing. And I think most of our problem is we get bogged down in process. We talked all about diabetes. What is the control of people who are on treatment for diabetes? Less than 10%. What is the control of people who are on treatment for hypertension? Less than 20%. What is the survival of people with cancer? We don't know now. So I think we have to change our approach, and this is something that sir has shown at that time. When I joined after MD radiotherapy from CMC Vellore in RCC, I was actually put in cancer registry. Nobody would go and sit there and look at medical records at that time. But I think that was such a radical change, and most of these studies actually came out of examining good medical records at that time. Again, RCC had such good medical records, which many hospitals even now don't have. This was my PhD thesis actually. We did the prevalence of human papilloma virus in Calcutta. This was one of the first studies we actually looked at, and about 5 to 6% was the prevalence, and the prevalence was persistent across age groups. If you see in high-income countries, the prevalence goes up to 20%, but it comes back. But it is the persistent HPV that leads to cervical cancer. Remember in 1993 when this study was started, there was not even a thought about HPV becoming a risk factor or a causative factor and a vaccine. Now, HPV is a vaccine for cervical cancer now. Many states, many countries have given. Harold Surhausen got Nobel Prize by showing that HPV infection actually causes cervical cancer. Krishnar sir had 339 publications. Imagine, it is not that he is writing 339. 339 faculty members of RCC and other places had a publication, that means. That means that is the kind of enabling environment that he provided. But still, what is the problem in cancer? In cancer, I think the main problem is delay. Delay is death in cancer. And for a person to have a suspected lump in the breast, to get a definitive cancer treatment, even in Kerala today, it takes almost 4 to 6 months, because they will go to 2 pathologists, 3 surgeons, 4 oncologists, and finally, by the time it gets done, it is too late. And in fact, when we developed the Kerala cancer strategy, we actually thought of a Kerala cancer grid, that within 25 kilometers, a person should get a definitive diagnosis, and that will save cancer. And thinking of that, in 2004, Krishna sir set up OncoNet, with which RCC Trivandrum could connect to Kannur and to various other places. And that was the kind of telemedicine that was set up. And in 2021, only Government of India has established the telemedicine practices, and Kerala is also part of that. If you look at India's National Cancer Control Program, which is one of the reasonably good ones from 1975, the main element which changed the initial plan was Krishna sir's 10-year action plan for cancer control in Kerala, which is again shown as one of the WHO strategic documents. I will not get into too much of details, but what is going on in cancer now? First, most important thing is that WHO has said that cervical cancer can be eliminated. Okay? It is not eradicated, it is eliminated, and the threshold is less than 4 per 100,000. So how is that going to be achieved? If 90% of girls are given HPV vaccine, in fact, the latest is that even 1 dose is good enough. 70% of women get cervical cancer screening, at least at the age of 35 and at the age of 45, with an HPV test, not just VAA or pap smear, which are very difficult. And 90% of such women and women with cancer get treated. Then we can bring down the incidence to 4 per 100,000. Trivandrum Cancer Registry has an incidence of 7 or 8 per 100,000, but I think across Kerala it will be much more than that. Plus our lifestyle and our sexual practices, everything is changing. So this is the right time for Kerala to introduce HPV vaccine. I think it is too late if you don't do it. I think Sikkim has, Punjab has, 2-3 other states in India has. Most other countries have already implemented that. So one of the major challenges, so by 2030, we should have a substantial reduction in cervical cancer, which is still one of the most common cancers in women in this part of the world. Breast cancer. Breast cancer is now overtaken as the single most important cancer, even higher than lung cancer across the world. Because of reduction in male smoking, lung cancer has gone down. And again, we really want to have an annual reduction of 2.5% in mortality from breast cancer, which mainly will attribute to early detection and good treatment. Again, cancer treatment has become a fashion of the day. Surgical oncologists, medical oncologists, all are there, but being in cancer for a long time, I can see that most hospitals treat cancer like fashion. What is the fashion today? So I treat it like this. And then 6 months later, somebody else will come and say something else. So I think a very systematic, thorough, protocol-based management with outcome assessment is still lacking, and this is something that Krishna has shown long back that it is possible. The other challenge is about screening. I think it is actually a misconception that everything can be screened and managed. Screening is good, but screening needs a lot of infrastructure and health system capacity to make sure that a woman who is screened is taken up to the logical conclusion of managing the precancerous lesion. Look at this breast cancer mortality curve from the US, 1950 to almost 1975. There is a rapid reduction in mortality incidence ratio. And then after that, after the introduction of mammography screening, there is not much reduction actually. In fact, if at all the reduction is there, that is actually due to tamoxifen, which came as an adjuvant therapy. And the last one that I wanted to mention about the global initiative for childhood cancer, where I think we should at least get a 60% survival for all childhood cancers, which I think again it is possible in Kerala. The current insights are all that you have heard, I think, yesterday about immunotherapy and microbiomes and DNA mutations, which I don't want to get into. And recently you heard that in one of the clinical trials of rectal cancer, all the participants were completely cured of cancer with immunotherapy. So maybe in 20-30 years, cancer will become a disease which still can be managed quite easily if you do a genome-wide analysis. Precision prevention is coming, but I just want to remind the audience that this is the life stages that we are familiar with, right? But is that the one? I would think these are the life stages. Our life stages are in bottles now, right? We start off with, instead of breast milk in artificial feeds, then it is in sugary bottles, then alcohol bottles and IV bottles. The problem is that there is a profit under every bottle. In fact, the fundamental failure of medicine, in my view, is that medicine has become a commodity for sale. And once it's an emotive disease like cancer, it is very easy to sell that. It is very easy to sell because it is such an emotive condition. So I think one has to really look at this. The latest paper from Lancet shows that still smoking alcohol, high body mass index, unsafe sex, and high fasting plasma glucose, etc., are still the highest risk factors for cancer. So what do we think Kerala should do? I think certainly tobacco control should continue, and newer forms of tobacco is coming in. Alcohol is also a substantial cause of cancer. You can see adult colon and rectum cancer is increasing in Kerala. HPV vaccination is a sure shot and should be given to all girls in Kerala. Targeted screening, not just widespread erratic screening, targeted screening should be provided. Protocol-based management with seamless transition. I think a cancer patient is sent from left to right in this state. I think there should be a seamless transition between public, private, and various levels. Financial protection should be thought through because out-of-pocket expenditure is still very high. We also need cancer navigators so that the person actually gets appropriate treatment at the appropriate time, and a state-level cancer registry so that this all gets documented well. Finally, even with all the changes, I think a chat scan is better than a CAT scan. What's a chat scan? You just talk to the person. You chat with the person. I think communication is so critical in cancer, which is missing completely. Instead of high tech, actually it should be a low tech and a high touch therapy. You should actually be in touch with the family of the person with realistic goals and consider that quality is more important than quantity. So I'll stop there. A candle loses nothing by lighting another candle, and that is what Krishna sir has shown. So thank you, sir, and thank you, everyone.
Thank you, Dr. Cherians. It was actually a befitting honor for the great oncologist, Dr. Krishna sir. So let me say some more things about cancer care in Kerala. At present, we should understand there is a paper which is published by Dundona et al. In, I think, in 18. And the Kerala and Meghalaya are the cancer capitals of the country. The maximum numbers of cancer are getting diagnosed here. And if you look at the cancer care treatment, cost of cancer treatment, and recently one of my relatives got diagnosed with breast cancer, early breast cancer, and with confidence she went to the nearest private hospitals where they discussed and explained the cost of the treatment. You know how much? It was 88 lakh rupees. The patient simply ran away and got treatment in a government hospital. So that's a kind of cost of the cancer which is happening nowadays. And if you think about the legacy of Krishna sir, as early as 1980s, he thought about standalone cancer care with the latest facilities, and it was, I think, one of the 4 centers in cancer, the best 4 centers in India, which one of was RCC. The other was Adayar, then Tata Memorial, Kidwai, and Ahmedabad. So, in 1980, he had a vision and he established a cancer care. But if you think now, how many standalone cancer care with all the facilities, with the multidisciplinary environment and all facilities are in Kerala, you don't see many. And now we can understand, even irrespective of the fact that RCC was established 30 years back, and even now, the major cancer care of Kerala is handled by RCC. There is something sad. If you think of any city in the country, Bangalore has at least 10 dedicated comprehensive cancer care centers in private sector. And Delhi has 20. And in Kerala, So you think about site-specific management of clinic cancers. Where is it happening? In RCC, we some sort of do it with a limited staff strength. But if you think about it, if you need to have a pure breast oncosurgeon and oncoplastic surgeon, is it available in Kerala? No. So it's very shameful for us to look at the pathetic and situation now. And I think Krishnadaya sir should have lived long, so that he could have created many more hospitals in Kerala. And nobody could emulate what he did, or even 100% what he did in cancer care. Really, we're really sad to say that. And I hope that this kind of discussions, thought process should evoke newer and newer ideas, and cancer care in India and Kerala should improve. Thank you very much.
Thank you, sir. We humbly request Dr. Y.A. Nazar to hand over a token of appreciation to the chairpersons, Dr. C.S. Madhu and Dr. Chandra Mohan.
You'll come back.
Next, we have a 10-minute break, after which we'll assemble by 5:30 for the book release.